but then you need to look out for electrolyte imbalances. So when you have to add hydrochlorothiazide to acutely decompensated heart failure patients, make a point of serially monitoring the electrolytes. A meta-analysis that looked at studies that have looked at thiazide-like diuretics demonstrated that metolazone is just as effective as chlorothiazide, and that's the reason as to why we do, personally, I use metolazone a lot. I have no experience with the hydrochlorothiazide. Advert trial released recently demonstrated, I know my time is almost up, demonstrated that when you add acetazolamide to high-dose diuretics, leads to successful decongestion, albeit acutely. So lastly, the role of ultrafiltration. So there are those patients in whom beyond high-dose loop diuretics, sequential nephron blockade, we still don't achieve the decongestion. So these are those patients who may benefit from ultrafiltration. A few studies have looked at this. The benefits have been rapid fluid removal with eventual reduction in the number of heart failure hospitalization. And the good thing about this is it tends not to be accompanied by electrolyte abnormalities as seen with the diuretics. But then there's no mortality benefit, and this may be accompanied by potential renal complications. So this one is reserved for those patients who are really refractory to all the diuretic strategies. So just to, as a practical algorithm, for patients who have advanced heart failure, we optimize loop diuretics. Go high dose. I know in the discussion we may talk about high dose versus infusion. Assess the response. If not good, then we have an option of sequential nephron blockade. The commonly used ones are thiazide-like diuretics. If this fails, then consider ultrafiltration. So in summary, residual congestion is a major driver of heart failure, hospitalizations, and mortality. Advanced heart failure is often accompanied with the diuretic resistance. So for that reason, we need higher doses of loop diuretics. And this together with combination therapy with in sequential nephron blockade with thiazides or acetazolamide. And in patients who fail the diuretic-based strategies, then you still have the renal replacement strategy as an option. Thank you.
Thank you, Dr. Anyira. Let's give him a better clap. I think if we get a few minutes at the tail end, you will tell us a little bit about the dose trial, if there was renal injury associated with high-dose diuretic strategies in attempting to decongest patients with acute and severely congested patients coming with heart failure. Our next speaker is both from here and not from here. It will be Dr. Titus Ngeno. Dr. Titus Ngeno is from Eldoret, you can guess, but is schooled in the University of Nairobi before doing residency and cardiology fellowship at Duke University in North Carolina, USA. He is an associate professor of medicine there and global health at the same place, and we collaborate a lot and do studies together for Moy University and Duke University. He's going to tell us some exciting things that is learned from there that relate to advanced heart failure and maybe touch on the kidney a little bit. Thank you.
Asante sana. So we will focus really on renal transplants and how to think about it as you approach this question where the nephrologist is saying, okay, we need to transplant this person's kidney. We know it makes their lives better, they live longer, it does all these amazing good things. But as a cardiologist, I think in the past 2-3 years, we're starting to tell them, just do what you need to do, get this person to make some urine, and then that way we can take care of other things down the road. When I first started out, I had maybe 50 slides or 60 slides. And then as the days have gone by and seeing all the content and things that have been done over the past few days, we're really trying, I think we could do all of this in 3 slides, but we'll go a little deep into it to try and talk through some of these concerns. And so the context to this and the question that's often posed is, we have a patient, 40 years old, end-stage kidney disease, been on dialysis for 3 years, and they say, okay, we know these people are at higher risk of cardiovascular events. What should we do before we transplant their kidney, or should we do nothing at all? An important background to think about in amongst these patients is recognizing that in as much as cardiovascular disease is the leading cause of mortality among patients with chronic kidney disease, a vast majority of this actually arises from arrhythmias and cardiac arrest, which said in a whispering sound is sometimes due to electrolyte derangements. But in a louder sound, in a louder voice, the fraction of those patients who have acute myocardial infarction as a driver of this is actually much smaller. The second part to this evaluation is to think about there are 2 people being evaluated. There's a person who is receiving the kidney, and there's a person who's donating the kidney. And taking care of both patients is, both patients are equally important. In fact, the donor, perhaps you need to make an extra effort to make sure that down the road, as you're thinking about their risk into the future, is well taken care of, as they are likely to have a reduced renal function, and you're essentially about to start putting on them some other cardiovascular risk factors. So one is to identify those who can withstand the preoperative surgical procedure as a recipient, and the other as a donor. Just by quick context, a person coming to you has had chronic kidney disease, end-stage renal disease, and now been in dialysis. We talk of vintage years, as there's a number of 5 years where you'll see once you get past the 5-year vintage, the risk of mortality is incremental. But we also think about what is the context underlying the pathophysiologic risk profile, whether it's the uremia and associated toxins and accelerated atherogenosis, where there is increased vascular calcification, and we think of complications from hypophosphatemia, hypercalcemia, and increased deposition, and the effects of hypervolemia and having this really challenging situation where some patients may have congestive heart failure, and they also have renal dysfunction, and you're struggling to take off volume. And as Anira was talking about diuresis and starting to think about, oh yeah, so what happens, how much volume can you take off with someone who is on dialysis and has congestive heart failure, and how do you figure out how much volume to take off without, in the absence of being able to use loop diuretics or thiazide diuretics? And in as much as they're saved from the diuretic effects and mineralocorticoid function, however, the renal disease in of itself causes bone mineral disease. So as we approach these patients who has been on dialysis for 3 years, as context set is, we think about, one, yes, all the traditional risk factors apply to them, meaning we think about their age, we think about diabetes, we think about dyslipidemia, hypertension, physical inactivity, and then there's risk factors that are specific to them having chronic kidney disease, where we want to make sure that we tackle bone mineral metabolism disorders. We think about the chronic inflammation we just spoke about with uremia. We think about proteinuria, vascular calcification, and then beyond the transplant, once they receive it, there's also the risk factors do not go, it doesn't fix everything, and they still have risk for cardiovascular disease. And we start thinking about the metabolic consequences of immunosuppression and the rejection and post-transplant complications and obesity that can arise from that. So the sequence is really have our initial risk stratification, where we think about the traditional risk scores, whether you want the MESA score, ASCVD, you have a large choice. And then you start wanting to say, okay, if now understanding this patient's risk profile, I want to exclude high-risk cardiovascular disease, because that then becomes meaningful in someone who's about to go surgical intervention. And then we also think about the assessment of cardiac reserve and recovery and optimization of cardiac reserve, not just around the perioperative phase, but into the future. The same sequence we do for all patients. We take a thorough history. We think about our physical exam. And the reason these two are important, as you will get deeper into this, we start saying, oh yes, so now the guidelines and the studies are starting to show us that maybe the biggest bang for buck in someone coming in for a pre-kidney transplant evaluation who's had chronic kidney disease for 3 years, has hyperlipidemia, has diabetes, has hypertension, that doing that risk stratification is truly informed by a personalized assessment rather than just purely the risk score as regards to what the outcome post-surgery is going to be. So I'll take a little deeper, because we are heavily data-driven, and sometimes I emphasize the history and the physical exam is really important, and I want to not understate the role of diagnostic testing, but we put a lot of data and numbers on diagnostic testing. Yes, we can do that, but really it's important that the diagnostic testing is informed by the initial assessment through our history and physical exam. And an important aspect to think about is what is available at the local center, what is reasonable, and at what stage in the person's kidney disease journey are they in terms of residual renal dysfunction. All patients ideally should get an ECG at the beginning. It's low cost, widely available, and look at the standard things, which is look for voltage criteria for LVH that gives you an inkling into left ventricular dysfunction, conduction disease, arrhythmia, prior infarctions. And it's also reasonable if there's concern for LV dysfunction to get an echo. Again, if you see a lot of these recommendations, and we'll go into this, it's really driven by your history and physical exam that will inform whether you really need to do this. Nuclear stress testing in the US, in Europe, is widely available, has been there for decades, not as widely available locally. I think now in Kenya, the centers, Aga Khan, KTRH, they're doing a lot more SPECT testing, and PET myocardial perfusion is also possible. And this is useful, especially it yields really opens a huge door for assessment among patients with chronic kidney disease who are unable to tolerate contrast and who have poor echo imaging windows. We'll talk about the constraints for cardiac MRI and gadolinium toxicity, which we think less and less about nowadays. We have emerging alternative contrast agents for MRI with ferraheme and different formulations that have lower iodine contrast contents on them. And so MRI, if available at a local center, is useful. And as you notice, I'm really glancing over these different imaging approaches, because it's really guided by two things, if I may set this in as the clock is going, is does a patient have symptoms? Is the result of the test going to improve risk for profile for the person beyond the transplant and not so much at the time of the transplant procedure? We've had a lot of questions around, can you use coronary CAC scoring, coronary artery calcification to score? And Dr. Lagat actually did a study to try and look at some of the prevalence of coronary coronary calcification disease, as you know, that a lot of the data sets that have been developed were not developed within our local population, and there has been in their ongoing validation studies, but it gets even more challenging among patients who have calcific depositional disease and chronic inflammation that can be challenging for them as well. Same for coronary CT, especially in younger patients, it has high negative predictive value. And then, of course, the gold standard is our invasive angiography. But again, my emphasis today is pump the brakes. Pump the brakes. The fact that someone has come in for pre-transplant evaluation does not mean that we need to go and look for angiographic disease from the get-go. It has to be driven by the risk profile and concern for high-risk incidents in them, and that it will make an impact down the road, and it does not need to happen immediately. I put in cardiopulmonary exercise testing, one, because I think it's going to likely change what the future for risk stratification is for renal transplant patients, as it has changed for heart transplant, for liver transplants. As we start thinking about this, is patients who have achieved meta equivalence of, we think of a cutoff of about 4, they're good to go for surgery. 7 is a better number, but as you have higher VO2 levels, it actually predicts with renal transplant and without transplant what their outcomes are, and actually it's pretty similar. So why all of this is becoming important, and I'm de-emphasizing a lot of the diagnostic testing. We've had, over the years, a lot of trials that historically excluded patients who are on dialysis or did not have high numbers of patients who had chronic kidney disease in them. I think some of the pivotal trials over the years, in fact, even ischemia coming in, did not have as much, but a lot of them showed that in patients who or on dialysis, when you do a secondary analysis of PCI versus or medical management therapy, including versus CABG, by and large, there's not much difference. FAME showed maybe some bit of a signal, but this ischemia CKD trial was a pivotal trial that came out right around COVID, as we were also getting some local data for CAC scoring here, is that death or MI did not differ between whether you intervened before surgery, did PCI or intervention or bypass before transplant surgery or not. And it said then, should we do anything at all? And that's the emphasis of today's conversation, is to say, okay, before you jump in and start saying, can we revascularize this person? They have this 80% lesion in the mid-LAD, should we put in a stent there? Or should we send them for 3-vessel bypass because they have diabetes? It actually is starting to, this has raised a question, should we just go ahead, take care of their renal dysfunction, and then thereafter reevaluate them down the road when they have symptoms? And so this is starting to change a lot of the guidelines from the AHA, ACC, that's a British Transplant Society. And quickly ramping up, we want to make sure that we also think about some of these other conditions that co-afflict patients who are coming in for evaluation, to make sure that we do not, as we said, the history is important. If they have pulmonary hypertension, as seen on some of the imaging studies, whether as changes on CT chest or changes on echocardiography, planning that in of themselves, they're not absolute contraindications to transplant surgery or renal transplant surgery, but we need to have a plan beyond that to have care and follow-up for them. And then lastly, if we think about post-operative surveillance and monitoring, it's really important to think about the highest risk is a early post-operative phase where there's a high risk of arrhythmias. Again, if you remember our first slide that showed the vast majority of sudden cardiac death among renal transplant and post-transplant patients is usually sudden cardiac death and arrhythmias, whether it's, which we suspect is driven by the changes in electrolyte balancing before they got the transplant kidney and post the transplant kidney. And then long-term surveillance is also really equally important to make sure that we keep track of their prognostic and risk mitigation into the future. And I think we're exactly at 15 minutes. Thank you.
Thank you, Titus. That was very clear. We'll surely have some questions at the very end. I will let my colleague, Dr. Vagela, introduce the next speaker. Thank you.
Good morning, everybody. It's very nice to see the hall filling up. We've been here for a while, and I know we are all very eager to learn. There's a slight change in program. We will have Dr. Anders Baraza next, who will take us through kidney transplant, an echo or an angiogram. I think none of us in this room could deny that we know Dr. Anders Baraza. He's been a great asset not only to the country, to KCS, and in the Scandinavian country as well. And he's always with us whenever called upon, whenever we've had to share anything. Anders is always at our disposal. And I will hand over the mic. He has to catch a flight, so we had to change that plan, but I know he'll have a lot to tell us within this short duration. Welcome, Anders.
Thank you so much. And first of all, where's Titus? So Titus covered a lot of ground, including my talk, but it's okay, because it's good to repeat, and it's good to maybe delve into some details. I'd love to see the other 50 slides you have, but he went through basically everything I'm supposed to say. How do I switch? I just say next? It is, great. So this was the original title, and it just didn't make sense to me, because you already outlined we need an echo, right? At least if you're suspecting ischemic disease. So I changed the title a bit. What test to do, what not to test, and what to do with the answer. So you need to really think about that in these patients, because you already mentioned that these patients have a lot of risk factors. And I come from the heart failure space, so the patients I get are quite sick, the ones I see. So I've used the HA. You also mentioned the KDIGO 20. So this is from here where I have so we're going to discuss a bit more about ischemia more than the whole patient. So screening is testing to detect previously unknown but clinically significant CHD in patients with no symptoms or no known disease. We need to really think about when is screening effective. We did some studies in Scandinavia where we tried screening people for different diseases in the GP and realized that screening actually in some patient population does not require anything. There's a risk of screening, something just to be aware of. Then the assessment you mentioned, and then uremic cardiomyopathy, and the clearance. The clearance problem is often you're asked to clear patient. Please clear the patients for transplant. And it's probably a terminology we should avoid. We don't clear for anything. What we do is we characterize the risk and state what's modifiable. So I think we need to get away with the clearance thing. Why do we screen? What's the rationale? This is from the CASC study. Any nephrologists here, maybe you've heard about it? Yeah, it's ongoing. We don't have the results out yet. That's going to be the big one that's going to decide what we're going to do. So you detect coronary disease, and then you try to correct it. And from societal view, especially in Kenya where we have resource restraint, we need to think about how many resources are we using to work up these patients if it has no effect. So the current strategy is not evidence-based, but we are probably working too much. So the question really was, should we periodically screen asymptomatic waitlisted patients for occult coronary disease at all? Number two, if a stenosis is found, does revascularization help the patient? It's just like what you mentioned, the COURAGE trial, the BARI-2 trial, the ischemia trial in non-dialysis patients. So assessment for everyone, I prefer to have a dry echo on everyone. And I really have to emphasize dry, because we cannot, you cannot assess cardiac disease when the patient is wet. And dialysis patients are very wet very often. So you have to understand, when was the dialysis day? Was it yesterday? Is it tomorrow? It makes a big difference what you're going to find on that echo. So make sure you arrange the echo at the time right after dialysis so you understand what the hemodynamics are when the patient is dry. You've mentioned this already, the preoperative functional capacity, symptoms. Symptoms is really key. T, and so I wrote TTE here at euvolemia. Then we move on to the mandatory echo parameters, ejection fraction, of course. Remember that a regional wall motion abnormality is the easiest way to detect whether a patient is very susceptible for ischemia. LVH, of course, many of these patients have LVH, almost all of the ones I see, but they're probably selected. So when a patient has dialysis for some years, they develop LVH. Then there's valve disease, of course, and RV function. Very important to make sure they don't have pulmonary hypertension. If they do, we need to figure out what's going on. Then there are the caveats, of course. Make sure the echo is dry. Pro-BNP is virtually, you can't use it for much, to be honest. Any nephrologist who disagrees? Pro-BNP is just really difficult in these patients, so I wouldn't use it for much. The METs is difficult. Many of them have PAD. Many of them just don't do very well on a CPET. Mitral annual calcification is very common. It's probably a red herring most often. And then very important to exclude the high flow AV fistula. That's going to give you a high output heart failure in these patients. So this is a bit busy, but basically you split between who's symptomatic and who's asymptomatic. The ones that are symptomatic, you need to think about them as if you're thinking about any other patient. You need to look, can we rule out disease? If they're younger, the CAC score can work, as you mentioned, but it's in the minority of the patients that I see. CCTA can be useful because you're looking for anatomy. You want to look at that very proximal stenosis that's going to be prognostically important to open. We use PET mostly. I don't know, I think there's PET in Aga Khan. Is there anywhere else that's PET, that has PET? Where? Okay, so we've got 2 PET scans. If it's done well, it's not that easy to do. It can be quite useful. Then in the asymptomatic, you're looking for prognostic changes. So left mains, proximal LAD. So that's really important to understand. So before you refer for an angio, decide what you're going to do if the patient needs a stent. Are you going to stent the patient? So you have to have an idea of what you're intending to do. So these are the modalities. You've actually already gone through this. Just remember that SPECT can be really tricky in these patients, and I wouldn't use, that's what we call myocardial perfusion. It can be balanced, that's a trick. CCTA, look for proximal prognostic disease. In Kenya, the stress test, echo stress test can be useful, but very variable in terms of what you get. So in some patients, it can be used for rule-in, and CCTA is more for a rule-out. Then there's ischemia CKD trial, you've mentioned it already. And it basically showed that a median follow-up of 2 years, a primary outcome of the event occurred in 123 patients in the invasive group and 129. So you can see the hazard ratio was 1.01. No effect at all in this subset of patients. Then there's the CAST view, and this is really, really important. It's an investigator-initiated trial, and is looking at specifically what we're discussing today. Will it work to look at these patients? What we're going to find is, hopefully, let me just go back here. I don't know when the results are out. Do you know when the results are out? No, but they'll be out probably within the year, or maybe 2 years. It's a study, unfortunately, only running in Spain, I think Spain, Germany, Canada, UK, New Zealand, Australia. So this will give us the answer as the first truly trial. Yeah. Then there's this very interesting trial that I saw just recently. It was also in cardiology this week. Very positive trials for fish oil. I have no clue how. There must be something, but maybe any of you can explain to me. Very positive trial with a hazard ratio of 0.57 for fish oil in these patients that have so many other diseases. I don't understand the trial. Maybe some of you can enlighten me. So, remember, non-ischemic causes as well, pulmonary hypertension. Make sure the patient is decongested before you determine whether they have pulmonary hypertension. If the patient is decongested and they still have pH, really important, just like in any other patient, you wouldn't send someone for surgery if they have pulmonary hypertension. And then AS, look for AS. These patients do really poorly if they have AS and dialysis. And arrhythmia, of course. The issue with arrhythmia, you mentioned, there was a lot of arrhythmic death, and the other thing was AF, of course. How do we treat AF? in dialysis patients. We still haven't really reached a consensus on that. I just want to mention from my own clinic, this is mostly my own experience with heart failure patients on dialysis. Carvedilol has the strongest evidence, and it also works pretty well in these patients if they can tolerate it. MRAs, I've been using them, and I just seen that a trial came out just very recently, which indicates that we shouldn't do it. Personally, I've had good experience with it, but this trial is actually neutral, completely neutral. And then finally, hydralazine, I've used with great effect in hypertensive patients. I work very closely with the nephrologist. I make sure that they adjust the dialysis to make sure the pressure comes down. But sometimes hydralazine is needed. And I've had very, very good outcomes in 2 or 3 patients using hydralazine. But just to remember, there's no data on this. The data are from AF, HF, and the new trial that's coming. So we don't have the data, but they're good at afterload reduction. So we do not clear patients. We characterize risk and state what's modifiable. That's for the cardiologist when you send these patients. Number 2, do euvolemic echo if you're looking for ischemia. Be guided by symptoms and echo findings. Positive ischemia test is not necessarily an indication for an angio. Make sure that if there's any other way you can get to figure out whether this is significant or not, do that test. Look for prognostic lesions. And then the available non-invasive modalities are suboptimal, and it differs from place to place. You have to adjust to environment. But I guess we could use stress echoes or CCTAs. But remember, if the cardiac CT is not done in a center that's used to doing these, it can be very difficult, because many of these patients will have calcifications, and then it's just null and void. And then look for valve disease, look for pH, and look for arrhythmia. So don't only look for ischemia. And then finally, if you have a patient with low EF, optimize the patient first before letting them move on. Sometimes we over-investigate and we actually delay to the transplant. So I think that's an important point. Thanks.
Thank you, Dr. Barasa. That was very clear. And we suspect you might leave early before Q&A because you have a flight to catch. Any burning question for Dr. Barasa? And before Dr. Ngunga, I'll not speak after the president. You left a very tough one for us cardiologists that you've documented ischemia. It's not, you don't have to go for a diagnostic angio, and that is a tough one for us. And then number 2, in most of our centers, we stress everybody pre-transplant. After nephrology said to them that clear this one for us, we take them through treadmill. Should we be doing that? And I have a story to tell about that. There was a patient in Eldoret who was being prepared for transplant for end-stage kidney disease. He was from Olenguruoni, which is in the Mau Forest. He came to clinic and he was telling me, "Doc, see me quickly because we have only one vehicle leaving for his hometown." So I saw him. I asked him, "What can you do at home as a way of assessing his functional status?" He said, "I can even plow the land with oxen." That is tough stuff. That's not for the ordinary. And then I saw him, I finished with him, and I scheduled for a stress test. But then when I looked out, the speed at which he was running, okay, and people from Eldoret, Titus will tell you everybody runs in Eldoret. And people run seriously. You can be doing your best and somebody overtakes you. And I can tell you for sure that guy was fast. Should I have done a stress test for somebody like that, Well, yes, the EF was good.
So, I mean, people do it differently. So the problem with stress tests, first of all, it's a very poor test for ischemia. Do we agree? It is quite a poor test for ischemia. That's why we stopped using it for ischemia. We use it for many other things that's very useful. But for ischemia, it's not a great test. I don't know how many patients I've seen, this craze of the Tour de France. They're all over the place, and then they fall down, they've got 3-vessel disease. You see that all the time. So we do cardiac CTs on these, and if we don't see any proximal stenosis, and the patient is doing very well, he's very active, then we stop there. We do echoes on everyone, so we'll know whether they have, because you have to, so the echo and the CCT is what we do. It's not the same, because it's a different environment, But that's basically what we do. So in your case, your patient would probably have had a coronary CT, which would have been normal, likely, and we've done an echo, yeah. So, and then the symptoms is really important. So if he tells you he's doing all these things, that's a really good sign.
Yeah, thank you, Anders, for talking. I was really following your presentation here. So recently we had a patient who had a low EF. I think it was like 30. We gave him medicine, it went like 35. And this man really wants a kidney transplant. So we did for him a stress echo. Lately, after almost like 6 months, almost a year, the EF now was like 35, it went up to 38. And I tried those maneuvers because I think the guy had no time or something. I walked him up the stairs and he was able to walk. What kind of contractile reserve would do, is recommended? I don't know, but what kind of contractile reserve would make you comfortable to send a patient for kidney transplant? Just asking, because these are sometimes patients we see. And also maybe for the purpose of the audience, when you talk of optimizing heart failure therapy in these patients who have kidney failure, really what are we looking at? What kind of drugs work for you?
Yeah, that's a great question. So we do transplant patients with heart failure, even with HFrEF. The main thing is how stable they are. Are they decongested? Are they optimized? Then you can still do it. You're looking at the, so basically what you're doing when you're transplanting is you're stress testing them. So if you make sure that they can do that stress, and you make sure that they have low filling pressures, and that they have a buffer, they should have a buffer, right? So you're testing that buffer, then you can still do it. What do we use for optimization? Well, I've just mentioned it. We use hydralazine, which is off-label. We use beta blocker. I use MRA, which is also off-label. I even sometimes use ACE inhibitors. And I just call the nephrologist and ask him, can I use this ACE inhibitor? And they usually say, yeah, go ahead. So we just talk and we just try to optimize the patient. We just want to get afterload reduction. If there's still angiotensive drive, it makes sense for me to use an ACE inhibitor. I'm talking about dialysis patients now, anuric, yeah? I'm not talking about all the patients. If the patient is above dialysis, it's a completely different story. Now you're preserving the kidney for other reasons. So you need to understand where the patient is. If the patient is fully on dialysis and completely, then you can go ahead and do some of these things, yeah.
I think excellent talk, Dr. Anders. Thank you for this. I would wish there would be more nephrologists in this audience today. And you know, usually what happens is the heart improves after the transplant, actually. And by preventing this patient to go for the transplant, you're actually, you know, giving him a mortality, a death sentence. And as you've said, you know, you don't do much. Even if you find an ischemia lesion, studies have shown that there's no benefit even in opening that. Okay, you put a stent, you put them on dual antiplatelets, wait, how long to do the transplant? Because, you know, the surgeons wouldn't be comfortable. So a lot of questions there, but excellent talk, and yeah. So
the pressure is really the important. The pressure is really the important part. That's when the patient will improve if they have a low EF. So just make sure you talk to the nephrologist. You make sure they're dialyzed far down. Make sure the pressure comes down. You'll see the EF just coming up even before the transplant. But as you said, most of these patients, they recover tremendously after the transplant.
The one thing I had is pulmonary hypertension. I mean, most of these patients actually have pulmonary hypertension, end-stage renal disease patients. So how much do you do for them, right? One thing which you said is very important, get the echo after the dialysis, because most of it is volume causing pulmonary hypertension. You know, I've had a couple of cases just last week. They go for right, left heart cath. Is it really necessary? No. You know, you usually don't see much there. What do you do next?
So if I suspect it's post-capillary, I'm fine with it. Then I have a good exam. But if I think it's pre-capillary, that means if it's on the lungs or to the right, then I work them up, yeah.
And last question before you sit, if you ended up stenting them, when do the nephrology come back to transplant? If they get a stent, you evaluate them and they have significant disease, and you feel you, as a cardiologist, you need to stent them. How much period do they stay before transplant?
So it depends on if it's an elective stent, it's pretty soon after. It's really a matter of the surgeon, and it's not a great risk. But of course, you have to wait. What's your take on that, Ngunga?
Yeah, so I think I would do two things. In the cath lab, we do have some stents, which they have told us we can reduce the adapt. So we have some, I think there is a one from Biotronic, they keep talking about 3 months. So there are some stent platforms which can actually allow a less adapt, so I would consider that. Number 2, I would consider a low adapt. I think 3 months is probably a fair time. So I would look for a stent platform with a low adapt, especially that I think that's in zero stent. And number 2, I would look for the 3 months. After successful transplant, I continue my adapt after a week or so for another maybe 6. The patients who are high bleeding risk and unfortunately kidney failures are there, 6 months is a good time probably to give you adapt.
Yeah, and the risk is, of course, you're now delaying again the transplant.
Okay, thank you. I think Professor Kuala has you have a mic. Oh, no. Okay. I think you'll agree with me that has been great. Please, let's give a hearty clap to. All right, we are covering good ground. I think our next speaker is Dr. Ihab Ali. Dr. Ali is from Eldoret. He's from the Sudan, lives in Egypt and works in Eldoret. He's an experienced interventionist and general cardiologist. I think it's not known to many of you, including our immediate past president, who kept asking him to, usually gives him the easiest ECG to interpret, that you don't want experienced people, you interpret for us this. And last year, he was given a pre-excitation ECG, which he made a meal out of. And this year, he was given an echo to interpret. So this is Dr. Ihab Ali, and he's an interventionist from Eldoret. He's going to talk to us about kidney protection in the cath lab, which he does every day. Welcome, Dr. Ihab.
Good morning. Thank you, Dr. Lagat, for kind introduction. And thank you, KCS, to give me this opportunity to talk about this topic. We will talk about contrast-induced nephropathy in the cath lab, how to make it safe. A lot of data talk about CKD is strongly predict mortality in the coronary artery disease, and also renal insufficiency increase cardiovascular risk even without standard cardiovascular risk factors. And even with mild elevation in serum creatinine, like 1.5 milligram predict future cardiovascular event. Contrast-induced nephropathy is the third leading cause of in-hospital acute kidney injury, and it is primarily caused by contrast-induced nephropathy and by post-bypass acute kidney injury. Contrast-induced nephropathy in the patient undergo PCI lead to poor procedure success, prolonged hospital stay, and increase in hospital mortality. This is here a basic for the property of contrast media. We should understand that because how it can make contrast-induced nephropathy. We have a high osmolarity, contrast, low osmolarity, and iso-osmolarity non-ionic. This is a common contrast we use. I think nowadays we use more of Omnipac, which is low osmolar non-ionic, and also the Visipac, which is iso-osmolar non-ionic dimer. Why we need a contrast? We need a contrast to use during PCI to attenuate the X-ray, to opacify the coronary artery. Every 125 mil of contrast can expand plasma volume by roughly 500 ml, and that was very basic and very important because when you are doing coronary angio, In a patient with low AF, you should consider that because you can do volume overload from just 125 ml of contrast. And it is eliminated through kidney, renal. This is some adverse effect from the contrast. It can cause allergic reaction and also some heart block, acute arrhythmia. And also it can cause vasodilatation, lead to acute hypotension and systemic blood volume overload. How we define contrast acute kidney injury or contrast-induced nephropathy? We have some diagnostic criteria. Absolute rise in serum creatinine increased by 0.5 or 1 milligram per deciliter after contrast exposure. Relative rise in serum creatinine increased by 25% to 50% from baseline value. Exclusive alternative kidney injury etiology must be absent. So sometimes it is challenging. Onset acute kidney injury manifests with 24-hour to 48-hour post-contrast after coronary angio or PCI. And peak and recovery, peak in 3 to 5 days, normalized within 7 to 10 days in 70% of cases. Chronic progression take up to 3 weeks to hit baseline or progress to CKD in 30% of patients. And characteristically non-oliguric AKI featuring mild proteinuria. We have a lot of data in vulnerability in the clinical data. Sample constraint, historically limited sample size, few patients involved, shortage of large mega randomized trials with wide variation in treatment and baseline rehydration protocols. And also the diagnostic drift, very clinical definition, heavily distort calculate outcome. So incidence by diagnostic definition rise in 25% creatinine, like 14.5 incidence, and also rise in more than 50% creatinine, like 4% incidence, creatinine doubling, like 2% incidence, and rise more than 1 milligram, 2.5 incidence, and post creatinine more than 5 or dialysis, the incidence was like 1.5. General incidence and risk predictor. Overall document incidence range dramatically from 1 to 35%. So to get contrast-induced nephropathy, it can range according to the risk factors from 1% in low-risk patient to 35% in high-risk patient. So this is most important to stratify your patient risk factors. We have non-modifiable risk factors and modifiable risk factors. Non-modifiable risk factor like pre-existing chronic kidney disease, diabetes mellitus, advanced age, more than 75, and heart failure, NYHA class 4, and prior renal transplant. Modifiable risk factor like when the patient is dehydrated, or excess total volume of contrast media. When you use more contrast, we will talk about that. Or repeated contrast injection within 72 hours. You do an angio, you find thrombus, you give anticoagulation, then you bring the patient again for another angio. Intra-arterial or intravenous administration and high osmolar contrast media usage. So high risk cutoff, impact of diabetes and baseline creatinine. And I think when the patient had diabetes and baseline creatinine more than 2, the risk will be very high. If we can look at this data, when the serum creatinine less than 1.1 and diabetes, risk will be 3.7. In non-diabetic will be less 2. When the serum creatinine is higher, the baseline 1.9, and diabetic, the risk will be go up to 4.5. And down when the serum creatinine 2 to 2.9, the risk will be up to 22.4. And when the creatinine baseline more than 3, overall risk will be very high, 30%. So also the clinical outcome, a lot of data also talk about when we have contrast-induced nephropathy, it will increase the in-hospital mortality and also the in-hospital stay. Also we have this Mehran risk score, very important for evaluation your patient before you start. So this is score when you have a hypotension or use of intra-aortic balloon pump support or advanced heart failure, you give the patient 5 points each. Advanced age 4 points, anemia or diabetes mellitus 3 points, and contrast volume you give 1 point for each 100 ml administration. When the serum creatinine 1.5, you give 4 points, and when the AGFR is low, also you give 4 points. So when you have a score of less than 5 points, 7.5 contrast-induced nephropathy risk, and the risk of dialysis will be low, 0.04%. When you have this score 6 to 10 points, the risk of contrast-induced nephropathy will be 14%, and when it is more than 16 points, then the risk will be very high and dialysis will be like 12%. So how we prevent a contrast-induced nephropathy? A lot of data studied, like more than 65 global review articles, and all these failed for the prophylaxis. Like they studied calcium channel blockers, adenosine, antagonist, dopamine infusions, mannitol to induce diuresis, furosemide-induced loop diuresis also, and endothelin receptor antagonist. And all this become negative. So the only things is positive is the rehydration regimen and to reduce the dose of the amount of contrast during the cath lab. So the standard protocol for rehydration from this paper, IV fluid initiate 1 ml per kg per hour at like 8 a.m. on the day of elective PCI or angio, continue for 12-hour post procedures. So also they like compare the normal saline and half saline, and it have that the normal saline is better outcome. And also they study the sodium bicarbonate, and also it failed to give any improvement. And also the N-acetyl cysteine also, it have negative studies. So I will go. So this also is important, adjust those contrast. We need the maximum radiographic contrast dose. It should be 5 cc multiplied by the weight in kg and divide by the serum creatinine. This is the total amount of contrast should be given. More than that, the risk of contrast-induced nephropathy will be very high. So also I find this paper with ultra-low contrast BCI, how to reduce the amount of contrast inside the cath lab. First, you need a good rehydration. Then you need, if you have a previous PCI or angiography, you can watch it because you need to reduce the amount of contrast. And if you can use IVUS or OCT also to verify your lesions, so you reduce the amount of contrast. From the key clinical takeaway, common complication, contrast nephropathy is frequent, serious heterogenic issue in a high-risk patient group. Long-term danger, even if serum creatinine retained to baseline, the 1-year mortality rate remain over 25% once contrast-induced nephropathy occur. Primary IV saline prophylaxis is strongly recommended from the recommendation. Contrast media selection, you should go for low or iso-osmolar. It is highly recommended also, and avoid high osmolar ionic contrast media. And the dose also, contrast dosing volume optimization is highly recommended. IV sodium bicarbonate and oral N-acetylcysteine generally is not recommended. Thank you.
Thank you, Dr. Ihab. Thank you. If there are any questions, keep it to the tail end so that we take all questions together. I will let my senior colleague introduce the next speaker and maybe take your questions after that, because this will be our last presentation. Thank you.
Thank you, Dr. Lagat. So the next speaker is Professor Ahmed Sokwala. He's based at the Aga Khan University Hospital in Nairobi, and he's doing a lot of work specifically in renal transplant, and he will take us through appropriate RAS blockade in kidney transplant patient. I know we have lots of gray areas in that region, and as cardiologists we are always a bit skeptical about using the RAS, so maybe Professor Sokwala will clarify a lot of these issues. Welcome, Prof.
Thank you very much, Dr. Wagela, and thank you, the Kenya Cardiac Society, for inviting me to talk here today, and thank you specifically to Dr. Lagat, who invited me, and I'm very delighted. I think this should be done more often, and I would say the nephrologists and the cardiologists are like, I think it's a marriage, right? Sometimes you have ups and downs, sometimes we love each other, but sometimes we go through that phases where you don't love each other. So I think these are it should be done more often. So I was told to talk about RAS blockade, but I had a freedom to push it to SGLT2, because that's the new thing in the realm of cardiovascular, cardiometabolic, everything you think about. And what about SGLT2 inhibition in kidney transplant? So I decided, let me add that as well. So if you have time, then we'll cover that as well, but I'll talk mainly about RAS blockade. So clinical scenario, typical patient, we have 58-year-old man, and those who have, clinics who have, patients who've had transplants. This is a very common scenario, you see that. On tacrolimus, mycophenolate, and low-dose prednisolone, gets a new onset hyperglycemia at 3 months and meets, criteria for post-transplant diabetes mellitus. Blood pressure 148/58. On amlodipine, GFR 52, urine albumin creatinine ratio is slightly elevated, BMI trending upwards because of all the immunosuppressive drugs he's taking, and has a history of coronary risk factors pre-transplant. So you asked whether you should start RAS blockade, and that's what Dr. Wagela was actually alluding to. There's no real strong evidence to it, but we'll see what evidence we have and whether we should start on those drugs. What about SGLT2 inhibitor, or you would give them both? So kidney transplant, gives you a metabolic risk. There is a risk before, and now when you add with the transplant, with the medications post-transplant, your cardiometabolic risk goes up. And now we'll talk about whether, how to reduce this risk. A lot has been discussed by my previous colleagues about CKD post-transplant, survival gains, but at the same time, persistent cardiovascular risk. There is heightened risk of coronary heart disease, heart failure, arrhythmias, valve diseases, pulmonary hypertension. We covered all that. This happens because we have a pre-existing vascular risk factor, the inherent risk of patients who are on dialysis for a long time. And then you have the superimposed cardiovascular kidney metabolic derangements after the transplantation. You have a post-transplant weight gain. The immunosuppressive drugs not helping the situation on the lipids, on the glucose, and on the blood pressure. And your de novo risk factors as well, so like dyslipidemia and diabetes. So it's like a continuum, and it combines all together, whether it's the transplant, whether it's the dialysis vintage, whether it's the metabolic syndrome after the transplant. So managements have been looked at, and multiple pharmacological therapies like statins, antihypertensives, and newer agents now like GLP-1 receptor agonists and SGLT2 inhibitors, whether modifying immunosuppressive regimen to reduce cardiometabolic effects must be weighed again in, you're balancing the steroids, you're balancing your tacrolimus, your CNIs, but at the same time, you're worried about a rejection. If you reduce those drugs, you're going to get a rejection. If you get a rejection, you have to give more of those immunosuppressive drugs, the more immunosuppressive. So it's like a vicious cycle. So post-transplant diabetes is a real story, and the risk is almost 7 to 39%. Patients who get kidney transplant get diabetes, and the reason behind it is the CNIs. CNIs suppress insulin gene transcription, hence causing diabetes. Corticosteroids, we all know, drive hepatic glucogenesis and impair the GLUT4, causing diabetes. Same thing happens with mTOR inhibitors and the chronic inflammation of the kidney disease. So 30 to 50% of kidney transplant recipients develop metabolic syndrome within the first year post-transplant. And I said this is like a vicious cycle, right? Immunosuppression and risk factors gives you metabolic syndrome, post-transplant diabetes, we talked about it. You get endothelial activation, complement-driven, you get antibody-mediated rejection, you have to give them more drugs, and then the vicious cycle starts again. So how do you prevent this? How do you, reduce the cardiovascular risk? So is RAS the answer to this? And, most of us, even I had to, when I was reading through this about RAS blockade and kidney transplantation, I was actually taken aback because I usually, it's a knee-jerk reaction to put these patients on RAS blockade. But we'll look at evidence. Evidence is what will guide us to therapy. We all know about RAS blockade, the physiological rationale in the allograft. Interestingly, when you transplant the kidney, the kidney, you're not transplanting the nerves of the kidney. So there's a lot of not the normal physiology which happens in a kidney transplant. And we know how the RAS cascade helps. And the physiological setting of the transplanted kidney is different because it's denervated, single kidney, usually with altered autoregulation. What happens when you give them the CNI? There is afferent vasoconstriction, all right? And now you're going to give ACE inhibitors. Will that change the intraglomerular pressures even more? So we'll look at, what evidence we have behind this. When I was in Canada, we had this huge trial, the Canadian ACE inhibitor trial, and we actually had some patients from our center into this. They looked at kidney transplant patients with proteinuria with a GFR between 20 and 55, and they were given 5 milligrams of ramipril twice a day compared against a matching placebo, and they looked at doubling of serum creatinine, progression to end-stage renal disease or death, And then the secondary endpoints were changes in GFR, and they actually looked at radioisotope methods, proteinuria levels, blood pressure, cardiovascular events, and quality of life. So we were thinking, things will be good, we'll have a drug which will help all that. But unfortunately, what was found that ramipril did not significantly reduce the primary composite endpoint of renal failure, end-stage renal disease, or death, suggesting no routine benefit of hard clinical outcomes in this cohort, right? So this was surprising, and we had pushed all these patients on ACE inhibitors. What do you do about them? Do you withdraw these drugs? Do you continue these drugs? There was a lot of discussions. Interestingly, cohort studies have shown there is benefit of ACE inhibitors, but when you look at RCTs, they're really, not strong benefit on that. And I've put up a couple of studies there. Everyone's looking for something to see whether there is benefit. Jiang et al., 24 studies, meta-analysis, 54,000 patients, ACE inhibitors, ARB, associated with decreased patient death, RR 0.64, graft lost, relative risk reduction of 0.59. Again, this was a cohort studies, most of them, but not confirming in RCTs alone. Again, 14 studies, Kung et al. Looked at that. Again, RAS blockade associated with low mortality and reduced allograft loss. Again, in cohort studies, but not RCTs. Same thing with Chung, not statistically significant mortality. So looking no much benefit in adding RAS blockade. Looked at Cochrane updates 2024 and compared different types of antihypertensive classes, CCB, ACE inhibitor, ARB. So the green one there is graft loss, and the blue one there, if I'm not colorblind, all-cause death relative reduction. As you can see there, CCB was the top one for blood pressure control in patients who've had kidney transplants, reduces death by 0.83, graft loss moderate, and reduce systolic and diastolic blood pressure. ACE inhibitors, little or no difference to death or graft loss. So those are the main things you look at, right? You want to prevent death, because that's why you're giving these patients kidney transplant. And there's no benefit whether on death or graft loss. Again, the same thing with ARB. I'm sure most of us have put patients who've had kidney transplant or inhibitors in IRB. So you're wondering what's happening now. Head-to-head comparison, CCBs and RAS blockers on renal function. So CCB versus placebo, GFR difference favoring the CCB, and CCB versus ACE inhibitor ARB. As you can see again, CCBs, 26 trials looked at, and reduced graft loss, relative risk reduction of 0.58. For ACE inhibitors, relative risk reduction of 0.62, and there was slight reduction in the renal function. As I say, there's no intraglomeralar physiology, just like the normal physiology, and there was some increased hyperglycemia, hyperkalemia risk. So again, favoring CCBs over ACE inhibitors, ARB. So what do you choose? Post-kidney transplant, your antihypertensive strategy, as we have seen, first line stays CCB, and this is really different than what we do for CKD diabetic patients, etc. But if these patients get proteinuria, if these patients get post-transplant diabetes mellitus, they get proteinuria, then, your ACE inhibitor, ARB, comes up in the list, okay? And then you have to monitor renal function and potassium as usual, and then individualize combination therapy. Obviously, do not combine ACE inhibitor and ARB. Okay. Those are the safety considerations you need to look at. You need to look at your drug-to-drug interaction. Concurrent CNI use, as I said earlier, causes afferent vasoconstriction. So you have to monitor your renal function very closely. There was an oncology session next, hematology oncology. So I said, let me put in something where I use ACE inhibitors in patients who've had kidney transplants. So this is a case here. 48-year-old male presents to transplant clinic 10 months post-kidney transplant. He's been well, just mild headaches, facial redness, end-stage renal disease secondary to polycystic kidney disease, and got an living unrelated kidney transplant. He's on tacrolimus, MMF, and prednisolone. His blood pressure 142/82, 88, heart rate 74. His hemoglobin is quite high, 18.2, right? And otherwise, his blood works are all okay. What do you do with this patient? You know, one trick I do for these patients whose HB is up is actually give them S inhibitor. So an S inhibitor actually reduces your HB in this patient. This term known as post-transplant erythropoiesis. And the way S inhibitors do that is, blockade of angiotensin II mediated erythropoiesis, reduction of EPO. And so this, patients who come with high HBs, post-transplant erythropoiesis, you can give them S inhibitors, and that will bring your, so it will be like, dual advantage. You treat hypertension, you're treating your post-transplant erythropoiesis. Great. So if we have time, we have 2 minutes. We'll try to cover SGLT2 inhibition, new frontier. Most of the studies actually, excluded transplant patients. The big trials like DAPA-CKD, all these big trials actually excluded transplant patients. So we don't have very strong data, but the small data coming in, more of, anecdotal data, some cohorts, some small RCTs. So one I looked at was the DIG study in Norway, randomized double placebo controlled trial, 330 patients, kidney transplants 18 to 75, EGFR more than 25, enrolled 6 to 8 weeks post-transplant, were given dapagliflozin 10 milligrams versus placebo, and followed up for 3 years. And the primary endpoint was chronic GFR slope over 3 years. We all know how SGLT2 inhibitors work. Proximal tubule blocks the SGLT2, causes glucosuria and natriuresis due to the TGF, causes afferent arterial vasoconstriction, hence reduces intraglomerular pressure and the other effects which are there. So what happened? There was, this was like one of the first trials looking at dapagliflozin. It lowered pressure, but not significantly. With the placebo, it wasn't significant. At 1 week, minus 3.9. So again, not much evidence in that trial. Okay. Then there are different other trials looking at, one of them is 288 kidney transplant recipients, chronic allograft dysfunction, again randomized to dapagliflozin 10 or placebo for 12 months. And there was a reduction in systolic blood pressure of 7, no difference in serious side effects. There was proteinuria drop, and there was less decline in the GFR with dapagliflozin. So a little faster, I have to go because of time. So there was, in real life, real world evidence in SGLT2 use in post-transplant diabetic mellitus. There was reduced decline in the GFR. So again, dapagliflozin is coming in patients who have post-transplant diabetes and post-kidney transplant, one of the drugs. Looked at side effects, not significant, whether it's urogenital infection, because these guys are on immunosuppressive therapy, worried about that, not significant in that category of patients. Okay. So SGLT2 coming into the realm of kidney transplants. Again, no significant difference in electrolyte or infection matters. So what about integrating RAS blockade and SGLT2? You would wonder whether decreasing the intraglomerular pressures even more will benefit the kidney, the graft function. Would prevent the worsening of the proteinuria, would prevent damage to the kidney by both adding an SGLT2 and RAS blockade in a transplant patient. Again, still work is being done in that. No significant studies looking at combination, but that is an area where more studies are needed, especially the RCTs. So key take-home messages: CKM, risk is compounded, not incidental. Kidney transplant recipients carry pre-existing vascular risk, post-transplant metabolic derangements, and we saw that post-transplant diabetes is not uncommon, 7 to 39% of kidney transplant. CCB remains first line for post-transplant hypertension, and we saw evidence to that. RAS blockade has a role, but a little more caveats because this is not the real physiology like the normal kidney. And SGLT2 evidence is rapidly emerging and encouraging, and more studies like this year, next year, waiting for more studies to come so that can be part of our armamentarium to use in these patients. Combination therapy may offer hemodynamic synergy, and this again, we're waiting for more studies on that. Thank you.
Thank you very much, Professor Sokola. We will get on to our Q&A session, and may I kindly invite all the speakers for this session to please come forward. Dr. Nira, Dr. Ali, Dr. Ngeno, as well as Professor Kwala. I think it's good to exercise. So colleagues, I think it's been a very, very enlightening session. Lots of new things coming up. Lots of question marks on how we are going to be using some of these molecules and how it will give maximum benefits to our patient. And with that, I would like to open the floor for any questions that we have. Please try and limit your questions. Keep them short so that we have more questions and we'll probably be able to engage our speakers more. Any questions? Welcome. Yes, Dr. Ibrahim.
Thank you. Thank you very much. It's a very interesting and enlightening session. Just a question or a comment. What's the role of dialysis after giving contrast? Because we see quite a number of times we've been told after using contrast, immediately go for dialysis. Is there any role for that? Does it really help?
Yeah, you can. All right. So there's actually no role of dialysis after contrast. You know, the damage has been done. If the contrast is going to damage the kidneys, the damage has been done. The only reason is, you know, doctor really put it well. 100 mils of contrast causes 500 mils of intravascular volume elevation, right? The only worry is, you know, it's not 100 mils only. It's a 500 mil increase in patient volume. If the patient has got pulmonary edema, if the patient, you're worried that, you know, will go into volume overload, these patients are usually oliguric, anuric, then you would dialyze after the contrast. But to prevent contrast-induced nephropathy, there's no benefit. We get this all the time.
Yes, President.
Yeah, thank you to the speakers. Every day we are learning something new. You know, one of the issues with CIN is prevention, and kind of people are still looking for the perfect medicine, including the group which sends people for dialysis. My question, Dr. Hab, and the question is, which marker can you test in people who have who you do procedures? Which marker can you test very early on to give you which patient is at risk for developing CIN? Because sometimes you want to know it within like a day or two, maybe before they leave the hospital, because the credit does not go up now, it goes up within 72 hours. Which is that one marker which you think is feasible and maybe can be utilized for doctors to know who is this patient, who is likely to go into CIN?
Yeah. Thank you, Dr. Gunga, for the great questions. Actually, we should prevent it. So before we go in to the cath lab first, as we said before, we should risk stratify the patient. And before we start our procedure, we should know first who is low risk and high risk patients. Then after you're done with the procedure, sometime you limit the contrast, but sometime the procedure can prolong and you can give more contrast. After that, you need to monitor your patient up to 72 hours with the serum creatinine to see the 25% rise or 50% rise, or also the urine output. And the nephrologist is here, can also.
Yeah, thanks. So obviously you have, nowadays there's, percentage, you have a calculator and it's available on your phones. So if you can calculate the risk of this patient. So what's the risk, okay? It depends on the amount of nephrons you're left in the kidney, right? If you have a good residual kidney nephron work, then you're less chances to get into contrast-induced nephropathy, because creatinine is not a very good marker to see whether you have an acute kidney injury. It goes up after 48, 72 hours. It doesn't go up immediately. There are other markers you can look at. So first, stratify your patient. Okay, avoid other nephrotoxins. What happens? How does contrast cause nephrotoxicity? It causes afferent vasoconstriction. Causes afferent vasoconstriction. If your volume deplete, what happens to your kidney? You go into probably acute tubular necrosis due to the contrast. Okay, that's the physiology. And if you have many nephrons remaining, so some nephrons will go into ATN, some nephrons won't. And the reason some nephrons are depleted is, one is age, the other one is diabetes, okay? The other one is CKD, okay? If your GFR is up, you have very few nephrons remaining. You're luckily born with 1 million nephrons, and it go up, down, with age. So then you might still get an injury to the kidney, but it won't show on your creatinine. So you assume that you didn't have a CIN, but you might have had, because there are other more nephrons working. So I think the best thing is just to calculate your risk and then avoid volume depleting agents. I would suggest, even until evidence comes, if the patient is on diuretics, hold off the diuretics, because you're going to give fluids. The only evidence behind preventing CIN is fluids. And if you're giving diuretics and you're giving it fluids at the same time, what are you doing, right? So, day before, probably hold off your diuretics, There's no, RCTs have not shown evidence by holding S inhibitors, etc. But again, what happens in, you give contrast, you get afferent vasoconstriction, you give S inhibitors, you get afferent vasodilatation, your intraglmerular pressure goes down, your perfusion to the tubules go down, you get ATN. So I usually tend to hold off as well the night before an S inhibitor and SGLT2. Again, there's no RCT to that.
Any other question? Yes, Dr. Mazo.
Excellent talks from all of you. My question is to the, or comment to the interventional cardiologist. Yes, I really agree with the issue of risk stratification. It's everything, risk stratify the patients. And then at angiography also, to reduce the incidence of CIN, it's very important for you to, from your clinical probability, to know which vessel you are most likely going to find pathology or even intervening, and then maybe try and choose the views that, sort of give you that anatomy. For example, if you know that you're going to be tackling the circumflex, there are views that best show you the circumflex vessel, or if it's distal LAD or proximal LAD, so that you restrict yourself to those views. And the fewer shots you take, of course, the less contrast that you're going to use. The advanced features in some cath labs, we have Philips Azurion C7, where you can actually just take one shot and it can give you like a whole spin of the entire coronary, so that you really just are focusing on one. I don't know what's your comment on withholding metformin in patients who have metformin at what eGFR, and then yeah, I think that's my question.
Yeah, so there is some evidence to holding off metformin actually, yeah, before the contrast.
Yes, Daniela, there was a question on the dose trial. Do we damage kidneys as we try to squeeze out fluid in advanced heart failure?
Yeah, it's a task you gave me when I finished the presentation. So the dose trial basically looked at the various dosing strategies of furosemide in patients who have acute decompensated heart failure, especially in the advanced setting. So looked at either high dose, low dose, and for the high dose, whether you give an infusion or boluses, and the outcomes. And the follow-up was largely looking at the patient symptomatology over 72 hours. The aim was to decongest the patient. So the high dose arm demonstrated that you decongested more, the patients felt a little bit more. But in terms of creatinine levels, you also had a relatively higher rise in creatinine levels in the patients who were put on higher doses. But then when they are followed up over time, the rise in the creatinine didn't portend poor outcomes. So the outcomes in both arms were, there was no statistically significant difference. And for that reason, I think you don't worry much about high dosing of the loop diuretics in those patients who are acutely decompensated. So because of the diuretic resistance, you still should go for the higher doses for a strategy that works, because the aim is you want the patient to feel better. Remember that in advanced heart failure, so sometimes, again, it's we didn't have enough time to discuss other strategies. These are patients in whom you need to start considering heart transplant, which in setups where, particularly where I practice, that is not something you even think about. Tito will chip in from his setting where he practices. But again, we need to start conversations around palliative care in those patients who really are advanced. But at least in terms of symptomatology, if the high dose gives us symptom relief, the patient feels better, push it.
Yeah, so the way diuretics work is they have to go into the tubule. And if you have CKD, these patients have cardiorenal. The dose is not enough to go inside the tubule to stop the sodium-potassium 2-chloride channel. So I agree with Doc, you need higher doses for that diuretic to go into the tubule and start acting. And then the braking phenomenon he very well explained, the braking phenomenon of, using these diuretics for a long time, you get hypertrophy of the distal channels, the sodium chloride channels, and that's why you use both, the loop diuretics and the thiazide to block both sides and cause more diuresis. Yeah, thanks.
And I guess in advanced heart failure, you also have the option of augmenting cardiac output by supporting with inotropic agents to improve perfusion pressures, and there you're able to get more delivery of the drug into the tubules.
Yeah. Okay, another comment?
Yeah, so we'll take two last questions in the interest of time. So maybe we'll start with gentlemen and then we'll come to Dr. Ibrahim.
Yeah, thank you very much for the great discussion. My question is on the contrast-induced nephropathy. We did say that the current strategy is to use 1 ml per kg per hour, starting in the morning and then continue for up to 24 hours based on the Mueller trial. But I'm just curious if the evidence for that strategy is enough, because in 2014, we had the Poseidon trial, which looked at the strategy based on the left ventricular end diastolic pressure. What are your comments on that, and if it is perhaps the time to also incorporate the use of left ventricular end diastolic pressure in the fluid resuscitation before the contrast? Thank you.
Okay, thank you for these great questions. Yes, actually, I didn't go through the much details. So, yes, you need, especially in the patient with low EF, you need to be guided these fluids by the end diastolic pressure. If you have a high end diastolic pressure, definitely you need to be very careful with the fluids. But if you have a good end diastolic pressure, you can apply that 1 ml per kg 24 hours. Yes, thank you.
Can we have the last question or comment?
The only question is, sometimes you don't have 12 hours post-PCI. The patient gets a PCI, wants to go home immediately, right? I mean, most of our guys, your cath lab is busy, you don't have a long waiting area, you know, and that's what happens in Aga Khan. Usually, Dr. Gunga can tell you, it's like a churn off. So what do you do in that case?
Usually we select the cases. If the creatinine is okay and you know how much contrast inside you have been given, it is less than 100 ml, just 80 ml, you can discharge the patient safely and the risk will be very low. But if you know you give a lot of contrast because technical difficulties inside, so no way you should keep that patient.
Yeah, so some studies have looked at boluses and they've also been similar. So you just give like, you know, 10 ml per kg bolus initially and after the contrast, and similar effects like infusions that you can do if you're in urgency of discharging the patient. And if they have no heart failure.
Yes, Dr.
The issue of assessing the patient, we need a dry echo. I have not heard anybody comment on the use of the Vexus grading to assess whether the patient is wet or dry. What do you think of the role of using Vexus grading to assess that?
Sorry, using exercise study?
Vexus grading to assess the systemic fluid overload.
So Vexus, the Doppler study?
Doppler study.
The Doppler.
Yes.
IVC.
Yes. So, one, in trying to assess whether a patient is dry or wet, especially in someone who has chronic kidney disease or in end-stage dialysis, the IVC is not very reliable in making that assessment, just because the plethora and over time, there's more splanchnic venous volume retention over time that helps to buffer some of the volume depletion. So I would not rely on that as much. The true, or one of the better indicators is if you have an understanding of the patient's prior dry weight, to try and get them as close to their dry weight before the echo study. There's also the confounder of an over-dialyzed patient coming in that gives you a false assessment of the person's resting situation. And so if you also over-dialyze, it may give you not a true picture, where you have an underfilled left ventricle. It looks like the EF is almost 100%, and the reality is you just have not, you've really taken off too much volume from the patient. And so that's why the dry weight and having a stable dry weight is usually helpful in knowing that the patient is just dry. So not too much, not too little. A little bit of, it's called a, I'm looking for translation for Goldilocks, right in the middle. It's not quite there. Yeah.
Thank you. And the test which the president asked, I don't know if he was thinking of Nystatin C or what, Professor Kwala, anything that you can diagnose badness real early.
So cystatin C is a better marker than creatinine. It goes up faster when you get a kidney injury. It's not a marker which will tell you whether the patient will get into CIN, but it will just, you know, if you get contrast, you don't have to wait 48, 72 hours to look at your creatinine. You can do it immediately within 12 hours, and if it's going up, then you know you have a kidney injury happening. So cystatin C, and there are other many more markers coming into the line. So yeah, you can use cystatin C for sure.
Okay. Okay, with that, I think we've done justice. Help me to thank the panelists. The Nyayo, let's clap like it. The Nyayo era moja, mbili, tatu, and clap for Dr. Vagela as well. You can.
Thank you all. Thank you.
And Dr. Lagat, you didn't clap
for Dr. Lagat as well.
I think we are done. The next session is on cardio-oncology. I think Dr. Mawazo is the one to guide us in that. We have only a few minutes. I suggest instead of going for a 30 minutes break, we just, I don't know, grab some tea and come back. We can enjoy tea here the way the setting is arranged. It is conducive for tea. So let's grab tea and just 5 minutes, and then we finish so that we go home early. Let's not leave Dr. Mawazo lonely, please. We come back quickly. Thank you. And clap for yourselves, I think. Next session.
is there.
I don't know if you cannot avoid. Yes.
wanakuja hapa wote wana present kama pande, si ati ni mmoja mmoja. So wako wote ndivyo ule moderator anasema nani anawawekea vitu ni wangapi? Ninamuuliza hapo pale tuongee na wao tunapange.
Yes, good morning, delegates, and welcome to our cardio-oncology session. We want to start. We are running behind time. My name is Dr. Kieran Mwazo, a consultant cardiologist and heart failure specialist with an interest in cardio-oncology. Today, honored to have an eminent panel of presenters who I'm going to invite to come up to the stage so that we can start. We are hoping to have some MDT sort of meeting this morning. So, welcome Dr. Kimeu, cardiologist from Nairobi. Dr. Anne Mwirigi, can raise up your hand. Consultant hemato-oncologist. Professor Arjun Ghosh, all the way from the UK Bath Hospital, Karibu, Kenya. We have Dr. Joseph Abodha, a consultant oncologist from the Aga Khan University Hospital, Nairobi. So it's an important day because we all know globally cancer and cardiovascular diseases are the leading causes of mortality. The two disease conditions have some shared common risk factors: smoking, physical inactivity, obesity, even hypertension, diabetes. They all predispose you to both cancer and cardiovascular diseases. There's been extraordinary improvements in the care of cancer patients such that they're living longer, and out of the new therapies, a lot of cardiovascular cardiotoxicities are coming in. So we can no longer afford to work in silos, in isolation. We've got to come together and really tackle these two epidemics together. So without much ado, I want to welcome Dr. Anne Mwirigi. Dr. Anne Mwirigi is a consultant hemato-oncologist who trained in the UK. She's been in practice for the last 10 years. She's handled a lot of cases. She's very experienced. And please welcome Dr. Anne Mwirigi. Karibu sana.
Is this mic? Okay. Yeah. Switch this one off. Oops. Okay. Good morning, everybody, and thank you, Dr. Mwazo, for making me at least 10 years younger. As he said, I'm Anne Mwirigi, and I want to thank Kenya Cardiac Society for inviting me. Also in my capacity as a representative of KESHO for this important discussion about cardio-oncology services, starting a program, and our patients. So my remit is kind of to set the scene from a hem-onc perspective to answer the question, why do we need cardio-oncology? But before we start with all the drugs and all the complications, I want to take us down a trip, down memory lane to talk about the evolution of cancer. So if you had cancer back in BC, 3000 BC up until almost the year 1900, all you could do was burn it or cut it because we only had surgery or cautery. And then in 1900, Marie and Pierre Curie began treating tumors using X-ray beams when they discovered that X-ray beams can melt tumors. But it wasn't until 1940 that chemotherapy delivering treatment into the bloodstream to treat cancer at source was developed, and this certainly cut deeper than the scalpel's knife or the radiotherapy beam. And then about 50 years after that, we then started to become a bit more intelligent in our treatment. Now the therapies are no longer just destroying cells that are dividing rapidly, which is what we all know cancer cells are, but they are treatments that can identify cell surface markers on tumor cells like monoclonal antibodies and then destroy them, or they can target molecular alterations that cause cancers. So that's like the tyrosine kinase inhibitor, the first of which was in 2001, and the monoclonal antibodies, the first of which was rituximab in 1997. And then the drugs got even more intelligent, where the monoclonal antibody can identify a cell surface agent on the tumor, but it is now attached to a cytotoxic agent. So once it goes into the cell, it destroys the tumor. And the effect of these treatments was to get deeper responses to chemo, deeper responses to cancer therapy, rather. And as a result, our patients started to live much longer. And we manipulated the immune system further by creating monoclonal antibodies that lift the brake on our natural brakes on the immune system, such as checkpoint inhibitors, and this allow your immune system to destroy the cancer. We manipulated things further with CAR T therapy, where our T cells are engineered ex vivo to identify tumors that are in our body and then injected back, and so we have an immune system that's targeted to destroy the tumor. And the result of this, especially these last three therapies, is deeper remissions, longer survival, fewer side effects of the type of neutropenia and hair loss, although those still occur, but a new range of side effects which are around the manipulation of the immunity of the body. The other thing I want to say about this timeline, you can see it took about 5 years to get to radiotherapy, and then it took 40 years to get to chemo, about 50 years to start getting to targeted therapies. But since 1990 until where we are now, there's been so many developments in cancer therapy that have gone really, really fast with good outcomes. It's therefore not a surprise that patients are living longer with cancer, but we're at the stage where we're asking, with what? And cardiovascular manifestations are some of the issues we're now dealing with, not only because our patients are living longer, so they are now developing conventional risk factors for cardiovascular disease off the back of the treatments that they had that could have long-term cardiovascular complications, or the tumor itself could have underlying disease effects, such as cardiac amyloid, a disease that causes arrhythmia. One of our colleagues was telling us yesterday about a lung tumor invading the myocardium, or indirect cardiac manifestations. But we're really here to talk about the contribution of novel agents to cardiovascular manifestations, as this is what really triggered this new specialty of cardio-oncology. So what did cardio-oncology look like back then when I was training? So it was really a binary discussion. You had a vulnerable heart, and then you were going to expose it to chemotherapy, most likely an anthracycline. We know anthracyclines have been causing cardiac failure for more than 50 years. Also radiotherapy, and then the heart would either, demonstrate resilience because it was able to withstand or adapt to the toxicity brought by the chemo, or it would go into heart failure. And so our approach back then was to stratify your patient based on age, cardiovascular risk factors, do an echo, and decide whether you're going to treat them with a full dose, a dose adjustment, or omit the drug altogether. But it was a bit reactive. There wasn't much about, can we make the heart more resilient? Can we prevent these toxicities? And the thing is, back then, there was really slow drug development, as we've kind of alluded to. You'd get a new drug, then you take a few years over here before you establish it as therapy, then a few more years before you discover and you're able to assess the cardiovascular toxicity, a few more years before you establish therapy of cardiovascular toxicity, and then a decade or two before the cardiologists and oncologists could quite comfortably manage these patients. And then that was okay, because then it was 20 years later before the next drug came up. Contrast that with our current current situation, you do not have new drugs coming up 20 years apart. You have this scenario where you have many drugs coming up very quickly. So if I take you through this particular drug here, the first one, we are trying to get it into the market. We are recognizing its cardiac side effects. At the same time, we are recognizing those. We have 2 or 3 more drugs that have come into the mix. So you don't really have the luxury of waiting to see what happens, and you know, you have to be proactive. This is where cardio-oncology comes in. You have to be proactive, identify your patients, risk stratify them so that they can complete their cancer treatment well without developing many side effects. And if you don't believe me about drug development, look at this. We talked about tyrosine kinase, the first targeted therapy. The first one was in 2001, and you can see for the first 10 years, it was roughly 1 new tyrosine kinase inhibitor per year, but by the time we get to 2020, there are 10 developed in that year, all with their own side effects, including cardiac side effects. So this is what cardio-oncology looks like now, with many more effects on the heart, and this is what Professor Arjun is going to talk about in detail. So moving away from all these complex drugs, I think I want to take us through a couple of cases which might be a little bit closer to what you and I might encounter during our routine work. So, case of a 75-year-old gentleman presents with severe dyspepsia. On examination, he's distressed and aphoretic, and he has an 8-finger breadth non-tender splenomegaly, and nothing else adverse. The splenomegaly is explained by the fact that he has myelofibrosis transformed from essential thrombocythemia, which was diagnosed when he presented in 2019 with portal vein thrombosis, and he's been on ruxolitinib, which is a JAK2 inhibitor, since 2021, and apixaban. His blood counts are similar to his outpatient labs, which show a leukocytosis, mild anemia, and severe thrombocytopenia. And his peripheral blood film is leukoerythroblastic with 7% blasts, in keeping with myelofibrosis. And we risk stratified him based on the myelofibrosis risk score, giving him a high-risk disease with a median overall survival of 1.5 years. So this gentleman also had a baseline ECG. I'll give you 10 seconds to read that. Thank you very much. And then I'll just tell you that 3 days after admission, at 4 a.m., he developed really worsening dyspepsia. Woke the nurses up, his BP's dropped. So they repeated an ECG, and I'll let you look at that again for a minute. And then did a troponin, which came back after an hour, at 904. So at this point, we have a 75-year-old man with a non-STEMI. His background is a high-risk myeloproliferative disease. He also has chronic severe thrombocytopenia and is on long-term apixaban. Remember, his platelet count is 35. So I'm going to pause for 30 seconds now and ask, what do we think is the most appropriate approach? Are we going to manage him conservatively, stop apixaban, start DAPT? Anyone? Raise your hands. Are we going to transfer him to the cardiac cath lab immediately for angioplasty and stenting, stop apixaban and start DAPT afterwards? Are we going to refer him to cardiothoracics for cabbage? Are we going to do an MDT with hematology, exploring etiology of thrombosis and balancing risks of various modalities of treatment, or 5 other?
Shall I ask a cardiologist to try to
Yeah.
answer that?
Yeah.
Can you play the ECG again?
Yeah, sure. Yeah, this is ECG at 4 a.m. He's got really bad dyspepsia. He's dropped his BPs from 130/70, and he's got a troponin of 904. He's 75 years old. His only past medical history is myelofibrosis, and he takes apixaban because he's had thrombosis in the past.
Yeah, he needs aggressive management with an angiogram. He may have a clot somewhere.
Okay.
So I agree. So
what
the story of median survival is in the book, but you can live for anything, can vary from 1.5 across the board.
So what are you going to do, Dr. Ngunga? I think you mumbled. I don't
you
think.
Find, yeah, sorry, I said the ECG. So this man has chest pain or
yes.
epigastric discomfort. The ECG is abnormal. He has troponin elevation, so he qualifies for SES. So if you find he has a thrombus, then the treatment is there are many things you can do. You can do thrombus aspiration. You can do, if you find severe stenosis, there is of course room for stenting. If it may be appropriate, then there's room for DCBs in people who are high risk for bleeding, so we do have that option lately.
Can I quickly ask you about stenting him in the context of platelets of 35?
That's a very good story.
Long term.
I had a patient recently, and I actually reviewed the literature. This is a very good discussion. I reviewed the literature of stenting in people with thrombocytopenia due to multiple causes. ITP, that man had ITP and he was actually on treatment. Platelets were 27. So for him, because the platelets were low, we put a DCB in that man. Unfortunately, he stayed in the CCU I kept seeing him there for like almost 3 weeks because of the ITP problems, and I think he had some other infections. And the literature is actually, if you are getting an MI with platelets of 27, it means the thrombotic problems are much more than can even be prevented by the platelet problem. So literature does show a lot of safety for actually treating SES in the setting of ITP and other, so long as the patient is not actively bleeding and if the primary problem is well treated. Luckily, there are options.
Thank you. So I think we've heard it from the cardiologist. We'll take the patient to cath lab.
What will you do after cath lab, though?
He's going to find out, is there thrombosis?
Okay,
aspirated?
fine. So this particular team decided to speak to hematology at 4 a.m. and they decided there's long-standing thrombocytopenia which limits the use of antiplatelet agents. However, although PCI should proceed, there shouldn't be stent insertion because that mandates long-term high-dose antiplatelet therapy. And so the patient did go for angioplasty. I don't know if anyone recognizes their writing there. There was a severe stenosis in the right coronary artery, and balloon angioplasty was performed and restored depth deployed, which I understand is a paclitaxel eluting kind of stent, and flow was established. So further discussions with hematology, since the thrombosis occurred while on apixaban, he does need another agent. So an antiplatelet agent, ticagrelor, was recommended, and for 6 weeks, an arbitrary time of 6 weeks, and to keep the platelets above 50 in this period. So this gentleman now has completed the 6 weeks. This happened in January. We're now in July. He completed the 6 weeks of ticagrelor. He continues now on apixaban and ruxolitinib. He's very well, and this is his current blood count. Second case, again, something you may encounter in the outpatients, 45-year-old gentleman. In August, he developed severe dyspepsia enough to take him to hospital. No real risk factor for this. A day later, he wakes up with a dull ache in his left shoulder and the back, and he says this pain was present for a month. Then he develops 2 episodes of right-sided numbness, which are self-limiting, but eventually the reason he comes to hospital again is because the numbness just settles in his chin. Examination is unremarkable. Cardiovascular risk factors, he's slightly overweight and smokes less than 10 cigarettes a day. He has an MRI of the brain which shows multi-territorial embolic stroke bilaterally in the cerebral and cerebellar areas, and I'll just show you the ones I could find there. So this gentleman, again, ECG. So because of this, it was suspicious of cardioembolic thrombus. So an ECG was carried out, which showed T-wave inversion in V2 to V4, suggestive of Whelan syndrome, and his troponin at that point was 68. So he went on to have an echo, which showed apical akinesis with an apical LV thrombus. And so the suspicion here that was a late presentation MI, so he went to the cardiac cath lab. They found 100% thrombotic occlusion in the mid-LAD. They struggled to recanalize it, really struggled to recanalize it, and even 3 days later there was still some thrombus persistent, and this was suspected because it was a delayed presentation with an old clot. So he was discharged on Ascard, Clopilot, Xarelto, and Lipitas. And then he was seen in clinic a few months later, and it was then realized that his platelet count had been high pretty much throughout. So this was 5 months after his initial presentation. So the cardiologist contacted hematology, who recommended MPN genetic testing, and his JAK2 mutation came back positive. So we did a bone marrow test, and what I can tell you is that a hypercellular bone marrow, and what you can see is that a cluster of megakaryocytes, which are the cells that produce platelets, and this is an enlarged version of that. And this one that looks like a staghorn is called a staghorn, and it's pathognomic of essential thrombocythemia. What was surprising for a 45-year-old is when we did the reticulin stain, he has grade 3 fibrosis. So you have a 45-year-old man with JAK2 positive essential thrombocythemia, which has now transformed to myelofibrosis, and he's got a thrombotic complication. So this is a very high-risk case, and this gentleman would be recommended for a bone marrow transplant. So this is just highlighting that even though, contrary to the old Mzee, whose DIPS was 6, giving him an overall survival of only 1.5 years, this man's overall survival is not kind of reached at all. But with grade 3 fibrosis, this is not a benign condition. This will progress. He will develop splenomegaly, he'll develop bone marrow failure, and as he's 45 and very well, this is the period to harness to send him for a bone marrow transplant. So this is just showing you an article that Professor Ghosh was part of, just explaining that although MPNs are associated with thromboembolic events, and we already know that, so we put all of them on aspirin. In this retrospective analysis, they found that the incidence of thromboembolic events was 26.7, with arterial at 15.8. And this was partly because some of the patients had cardiovascular risk factors, but some didn't. And there's a strong, I'll call it a feeling, that the JAK2 mutation could independently be associated with arterial thrombosis, irrespective really of very high platelet counts. This man's platelets were 602 and odd. So this is just showing us that several things could be happening at the same time. I'm a humble hematologist, so always look at your platelet count, always look at your hemoglobin, always look at your hematocrit, because there could be something else, especially in these young patients, going on. So over time, but I think I'm forgiven. This is going to be hopefully a very useful session, and these are going to be your learning outcomes at the end of the session. Thank you very much.
So thank you so much, Dr. Mwirigi. That was amazing. 2 cases presented where the cardiologist is needed. So now we are going to have Dr. Mwazo going in, and is going to speak from the cardiologist's point of view. Dr. Mwirigi gave us the oncologist's point of view of these patients, and we'll have Dr. Mwazo coming in.
Yeah, so for me, it's cardio-oncology at Mashinani. I'm Kieran Mwazo. I work at the Coast General Hospital, where we have a cardiac center and a cath lab, and we give service to our very robust oncology department. We have radiotherapy. We also have chemo. We also give chemotherapy in this. And I want to thank Kesho, represented here by Dr. Anne Mwirigi, and KCS, Professor Ngunga, for giving us this slot at KCS. I am not going to say much. There are nearly 50 million cancer survivors globally, resulting in part from the extraordinary advancements in oncology treatments. In Kenya, cardiovascular disease and cancer combined, the two are leading in terms of mortality. And the new therapeutics for cancer, they're growing exponentially. That has been alluded to by my predecessor, so I'm not going to spend much time talking about that. I'm just going to share the burden of cancer at our local institution. As you can see at CPGH, the top 10 cancers, 34% of them, of the top 10, is breast and hematological cancers. These are populations that get routine exposure to the cardiotoxic therapies, anthracyclines, and HER2 receptor targeted agents. So this is a problem that is there that I've got to deal with. So the role of cardio-oncology essentially is to work with oncologists in the pre-treatment era to risk stratify these patients, and then when risk assessment is done, to sort of follow up these patients, do surveillance for toxicity, investigate these patients, and then continue to follow them up post-treatment and into the survivorship program using various imaging modalities, echo, MRI, CT scans, and all that. There have been many societies which have tried to come up with the guidelines on how to follow up these cancer patients, from Heart Failure Association, the American Society of Cardiography, ASCO, ESMO, but we are glad now in this day we are being guided by the 2022 ESC guidelines that put together the Hematology Association of the ESC, the European Society of Therapeutic Radiology and Oncology, and now the International Cardio-Oncology Society. So now we have one set of guidelines that we follow so that there is no confusion. There is a slide that I'm not able to see, but I want to spend time today just teaching you how to do baseline cardiovascular risk factor assessment. The guidelines that we normally use are the Heart Failure Association, the ESC guidelines, and from these guidelines there is a Heart Failure Association International Cardio-Oncology risk stratifying score that basically has clinical parameters, biomarkers, ECG and echocardiogram to sort of risk stratify patients into a risk category, and from that risk category you basically are going to know how to do surveillance on this patient. So this HFA ICOS score basically takes care of 6 drug classes. It applies to anthracyclines, HER2 targeted therapies, VEGF inhibitors, RAF and MEK inhibitors, multi-targeted kinase inhibitors for CML, and also multiple myeloma. So I had a case of a cancer patient who had a lymphoma, and so because my patient has lymphoma, he's going to get anthracycline. So you just take that up, the HFA ICOS, it's available online, and you choose that the patient is going to receive anthracyclines. So there are a number of issues that you look at. Biomarkers in this patient that I can see the slides here were elevated. This patient had diabetes and hypertension. This patient had a low EF. The ejection fraction was 35%. They were 55 years old. They didn't have any other lifestyle risk factor. They were not obese. They never smoked before, and they had not received any prior chemotherapy. So it was a new diagnosis of cancer and heart failure at the same time. And now putting it there, essentially this was a very high risk patient. The issue is what are we going to do in this patient? He's going to need anthracycline. He has a heart failure with reduced ejection fraction. He's a very high risk patient. So this same risk score tells you how to follow up this patient. Okay, being a high risk score patient, we basically did baseline ECG, echo, biomarkers, and then at baseline, and then this chart tells you that after the second cycle of chemotherapy, you need to do an echo again and biomarkers. After the 4th chemotherapy regimen, you do the same 6th, 3 months after completing the chemotherapy, and even up to 1 year and even beyond. So there is a very structured way on which you're going to follow up this patient. And these guidelines also give us also the follow-up strategy for the other different chemotherapeutic regimens that these patients. So it's a very easy tool to follow, and it's available online. You can upload it. As a cardiologist, I'm often called to provide acute care to patients who have cancer. Acute coronary syndromes have been mentioned by my colleague. The differences between ACS in the Guardian variety, the normal patients that we have, diabetes, hypertension, and a cancer patient, there are peculiarities that have been mentioned by my colleague. Acute heart failure, we see that the case I was going to show here is an acute heart failure patient. Myocarditis will be discussed by my colleague, and arrhythmias. I'm often called to see patients who have pericardial disease, pericardial effusion with impending tamponade, and even venous thromboembolism. So this is one case that we were asked to see is actually a case of thromboembolism, and many times thromboembolism can be the sentinel event that leads to the diagnosis of cancer. So this patient presented with acute chest pain, and in the process, there were actually the ECG, as you can see there, is highly suggestive of an acute coronary syndrome, almost Wellen type ECG precordial T-wave inversion. The left side ejection fraction was normal, but the right heart was dilated, and there was actually thrombus in the right ventricle. The challenge with the cancer patients is that they may not be amenable to the normal treatments that you normally give any patient, like thrombolysis, because they have hematological abnormalities, the platelet counts are low, so they are at both increased risk of bleeding and increased risk of thrombosis. So if you're in a center that has advanced therapies, you can actually do catheter-directed thrombus aspiration, but you've got to work with what you have. Many times, like in our patients, we basically ended up giving them the anticoagulants and praying for them, and unfortunately this patient demised. Yeah, so I'm also called to see patients who have pericardial effusion. Effusions, as you can see, this is a patient in Mashinani all the way. The issues with the pericardial effusion is in cancer is that again, there is recurrence. A lot of the times the cancers, the effusions recur. How do you drain them? We normally drain them under echo guidance, and the difference is the fact that if they're going, because of the high likelihood of recurrence, we normally leave a catheter there, a pigtail catheter, to drain for a few more days, and this has been associated with reduced incidence of recurrence. If it recurs many times, surgical referral is also a possibility. Yeah, so I think I've given the answer to that for the sake of time. We have a radiotherapy unit. We envisage that in the near future, we'll have a lot of pericardial disease from radiation, valve disease again from radiation, coronary artery disease, premature coronary artery disease, and also conduction abnormalities. So the way we do it to mitigate the effects of radiotherapy is to try and do cardiac sparing planning. There are strategies like deep inspiration breath hold, dose-informed follow-up, flagging patients for closer review by cardiac radiation dose, shared surveillance between the oncology department and the cardiology. We are also often called to see patients who have pulmonary hypertension. This is a slide I borrowed from one of my teachers. Pulmonary hypertension is quite prominent in patients receiving cancer therapy, from the cancer itself, from the chemotherapy, the drugs that are notorious, the proteasome inhibitor, carfilzomib, the TKIs, bosutinib, dasatinib, ponatinib. All this, when you have this patient, you really have to try and identify, is it type 1 pulmonary hypertension, for which you can give targeted therapy, because these patients also have many times coexistent left heart disease, or is it post capillary pulmonary hypertension, so that you're able to guide your treatment. So essentially, we are working together. The idea of cardio-oncology is that we can support the oncologist so that we minimize cancer treatment interruptions as we continue to give minimize clinically relevant cancer therapy-related cardiovascular toxicity. After treatment, you've got to risk stratify them again. So we risk stratify them at the beginning of the treatment, and then on the basis of their risk, whether they are low, medium, high, and high risk, we know how to do the surveillance. But after treatment, you still go back and risk stratify them again to know for how long after the therapy do you need to follow them up. Those who have received, for example, chemotherapy combined with the radiotherapy may need very long-term follow-up. Again, I want to invite you to our heart failure masterclass in September. We'll have a whole 2 hours of dedicated to cardio-oncology. If you really want to learn more, please, you're welcome. Thank you very much.
A lot of claps for Dr. Mwazo. Thank you so much for that amazing talk. You've taken us through what the cardiologist sees, the patients who are sent to us by the oncologist. Next, we are going to be calling to stage Dr. Abodha is an oncologist working at the Aga Khan University Hospital in Nairobi. He's going to be presenting to us some cases which will touch on patients who are on treatment for oncology patients on treatment and presented with cardiology complications. Welcome.
Thank you. Thank you, KCS, for this invitation to give this presentation. Thank you also specifically, Dr. Kieran, for the invitation and for facilitating this, and to all the delegates and participants. You've heard from my colleague, from a hematology-oncology perspective, you've seen about myelofibrosis. I want to take you through some cases where these issues actually came to the forefront and treatment was affected. So the first case is when loss of limb is close to the heart. This is a 52-year-old male, rather fit. He has no issues if you look at his background and his social history. He's a policeman, never smoker, good functional class, no issue, only apart from a cousin with prostate cancer. But he had always osteoarthritis, from which he was follow-up. Okay. So from the hip pain, he ended up being diagnosed with osteosarcoma at the age of 52. Chronic left hip pain, he underwent relevant evaluations. Imaging showed this mass of malignant bone lesion. He self-referred again to India for that. He went through several evaluations, MRI, PET scan, found to have localized disease, and underwent resection of this particular lesion. It was about 19 centimeters at maximum length, with no nodal involvement and no metastatic disease. So he came to us with a confirmed diagnosis of chondroblastic osteosarcoma. Of course, we worked him up and did an MDT discussion as is standard, and based on all his evaluation, he was labeled very high risk. Now, because I think there are no oncologists in this room, just to give the data, you have a 2-year recurrence rate of 80% post-resection of osteosarcoma. So with adjuvant chemotherapy, this is reduced by more than half, and the recurrence rate is less than 40%. So you have a very good chance of actually ensuring, and this translates to an overall survival benefit. And in a young person, relatively young, 51 years old, the decision was adjuvant chemotherapy, and the recommended regimen is anthracycline cisplatin-based regimen. Now we know doxorubicin has its own cardiotoxic effects, so we did his initial workup as a standard as it has been approached. His EF was 50 to 55. It was actually close to, I think it was 52%. His GLS was -14. He had grade 1 diastolic dysfunction. His RSVP was that. And his ECG just showed a sinus rhythm. He did not have any other issues. So I'll just take you shortly through his timeline. He had his first cycle of chemotherapy, cycle 1, day 1, a little bit interrupted just because of toxicity side effects. Then he had his second cycle 3 weeks later as per protocol. During this period, prior to administering his day 2 chemotherapy, he was noted to be bradycardic. Now this was a new event. He had rates of about 35. So we stopped all treatment. We immediately got an ECG, which showed various abnormalities with sign of pauses. Do I think I have it? Yeah. So he had this, this is the ECG. He had the ECG done. You can take a look at it quickly, which showed sinus pauses and probably AV block. After that, he was seen by the cardiologist who ordered a 24-hour Holter. He had these various heart rate trends during the 24-hour Holter period. He remained asymptomatic otherwise from that particular episode. But at the end of the Holter monitor, his rhythm abnormalities was identified. He had several problems. Tachys, bradies, PSC burden elevated, QTC average was low still. He did not have any AFib, but he had a definitely first degree AV block, and it was a Mobitz 1. So, I put this to the audience. You have this gentleman, he's only done 2 out of 6 recommended chemotherapy sessions, not even 2, 1.5. He's developed this cardiovascular abnormality. We know that the benefit of chemotherapy by evidence is there, it's not without doubt. But he has this issue going on. What do you do? Do you continue doxorubicin cisplatin? Even though you correct everything, do you just stop all therapy, no more chemotherapy, heart is evaluated, no more chemotherapy despite the benefit? Do you stabilize the heart, and if it's okay, still continue with chemotherapy, knowing that it's already had an event? And you need to continue chemotherapy and protect the heart, so you put a pacemaker. and proceed with the treatment. I don't know whether you have any takers here. None.
Anyone want to give their recommendation?
Okay. You call the cardiologist.
Call the cardiologist. Okay, let me find a cardiologist. Disadvantaged.
I mean, there's no right or wrong answer. It's just about assessment.
Yeah.
Oh, thanks, Dr. Samia.
Yeah, so it's a tricky one. So this bradycardia is developing, and of course we're worried that it could lead to a catastrophic event. I think the immediate thing is to just go through stop the chemotherapy for now, evaluate the patient again, see could there be any other reason that is contributing or precipitating the bradycardia, any other meds in the setting, electrolyte abnormalities, infection in the setting, and so on. And once the patient is stable, I'll probably give another try of the regimen, probably a more modified administration of the chemotherapeutic agent. The pacemaker, I think, is a bit too soon to consider it. This could be a transient rhythm disorder that would resolve. So I would temporarily stop, try to stabilize the patient, and reintroduce the chemotherapy again.
All right, thank you so much. So he did have impression. He did an assessment. Of course, like you rightly said, the leading concern was his cardiac problem. The problem was this was in an oncological context, and the benefit, both of them can have both adverse outcomes if you ignore them, so you have to do them in concert. So the recommendation at that time on evaluation was we need monitoring, of course, stop everything, do workup has been as suggested, we did the CFTs, troponins, and NT-proBNP, look for infection, and they all came out normal. She was given perindopril for cardioprotective effects of the ACE inhibitor. Beta blocker was deferred, and the reason this was deferred because he had these bradycardic episodes, and though it was indicated for suppression of PSCs and PVCs, now the pacemaker option was raised, and we had a discussion in tumor board again, both oncology and cardiology. And two options were floated. One, do you, after stabilization and investigation, do you do a pacemaker now, or do you do surveillance as you had it being alluded to? Both options were floated. The strongest one that was given for continuing with chemotherapy was actually doing the pacemaker, because this will allow us to have safely, because it can have another repeat event, and this might tip him over to a more fatal outcome. However, we did a cardiac reassessment immediately after this, and his EF had actually normalized, his ECG had normalized, and indeed it was a transient episode. So the question is, would you still continue with chemotherapy at this point in time, or do you still pursue the pacemaker option, knowing that it can happen again at that particular point in time? And that question still remains unanswered. But the key learning points, and I'll leave that to your thinking, as Professor Ghosh will come in and talk about certain nuances, is that there are usually competing priorities, especially when you have such events, especially with cardiac and oncology patients, and GLS is an early signal. Just a quick one last case is also, I've talked about an uncommon event in an old drug, but now I want to talk about an uncommon event in a new drug. As Dr. Murigi had talked about, we're in an era where every year we have 10, minimum of 10, maybe even upwards of 20 new medications in the oncology space being approved. And this case is a case of a 38-year-old lady. Now they're commonly coming more and more younger in our oncology clinics. Breast cancer, metastatic, initially non-metastatic, but she's other as well. She had a long decade of treatment. So this is a kind of patient who very soon will be kind of very common in our doorsteps. She was treated from 2013, and her last events happened in 2023, a whole 10 years later. And she lived a very good and fulfilling life. But as you can see, she had anthracyclines in 2013, and then she had multiple other therapies in 2019. But in 2022, of course, we had a receptor dilemma when she had a recurrence. We evaluated it, and the medication that was approved, at least for both types of receptors, was sacituzumab govitecan. Now, sacituzumab govitecan, as early as January this year, has been approved for triple-negative breast cancer in the first-line setting. The approval for this particular indication was last year in October. That's how new it was. Of course, there was no cardiovascular signal in the ACCENT trials and the TROPICS trials. Now, she received this treatment. Initial workup was fine in terms of echo, which had been done given her pre-anthracycline exposure 10 years earlier. But the second cycle of chemo, which was on 17th of February, she had abdominal pain, vomiting, nausea. These are known expected side effects. More than 50% of these patients will get these problems. She was seen here in Mombasa. She was seen in the Mombasa hospital, found to be pancytopenic, febrile, and she was immediately referred to us on Aga Khan for evaluation. On arrival, of course, those are her labs, neutropenic, and she also had an elevated troponin of more than 38,000. LV ejection fraction was 20 to 25%. Creatinine was 150. This could be a type 2 MI, but could it be something else that could be going on? She definitely had what looked like a features of infection, and the pH was 7.44, but the lactate was not too high at 1.9. So at initial evaluation on arrival, we had 5 converging problems. We had neutropenic septic shock, heart failure with reduced EF as noted. Of course, we had the acute kidney injury, most likely due to hypotensive episodes. What I did note before, she had autoimmune hemolytic anemia, which had been diagnosed a year earlier when she was undergoing cancer treatment. And of course, we have 10 years history of metastatic breast cancer. What do you do? Of course, she has this sepsis, which is being managed. But concerning the elevated troponin and the sepsis and the low EF, what do you do? She's end-stage metastatic disease with sepsis. Just know and don't do anything to the heart, leave it alone. Just deal with the sepsis. If she makes it out of it, you're fine. Or you say, no, this is just a bit weird. She just had a normal echo before. Do we do an angiogram? Do you read a coronary cause? And we just start guideline-directed therapy. Do you just start guideline-directed therapy? And we don't know too much about sacituzumab govitecan. It's a new drug. So do you just do a cardiac MRI, evaluate for myocarditis, continue other sepsis management, of course, or do you just do GDT? No, do further workup, manage sepsis, acute kidney injury. If she recovers, fine. She doesn't. She's 10 years down the line, she's fine. What do you think?
Yeah, very, very, very complex one. But I think from what is most obvious to the clinical eye, it seems there's some sepsis going on which we need to treat. Just take care of that and then start on guideline-directed medical therapy. And I would go with 4, basically, as we do other cardiac workups. I'm not really thinking about an MI at this point in time.
Fantastic. Thank you for that. So those are the cardiac parts. In terms of, just in addition to the troponin, what I didn't put, she had an ECG done, which showed an ST elevation at V5, V6. Now, with troponin, with that and elevated troponins, she was elected to go in for a coronary angiogram, which showed unobstructed arteries as well. And the echocardiogram we'd already seen, there was a severe globally depressed LV function, which could have been contributed. Maybe the previous echo, which was done externally, was reported wrongly. However, this was further complicated by atrial fibrillator and VTAC and V-flutter, which immediately after the angiogram, she had atrial flutter, she had worsened respiratory distress, and she went down the pathway, in terms of end of her demise. And she died within 48 hours of presenting to our institution. The learning point is sometimes we have these oncology patients who present with toxicities, and these toxicities can lead to competing interests about what do you do about something. If this had been a patient without neutropenic sepsis, probably you'd think otherwise about evaluating the heart even more further. But this is also a 38-year-old lady. You can imagine she was diagnosed at the age of 28. So she also has a very long life ahead of her. What do you do? How far do you go? So I think I'll close the presentations there.
Thank you very much, Dr. Abwotha. That's an excellent way to segue in our final speaker, a really difficult to pronounce drug. Oh, sorry. Well, yes, a really difficult to pronounce drug contributing to a patient's dramatic device. But before I introduce Professor Ghosh, I'm going to ask Dr. Kimeo to bring a case for us as well. Karibu, Daktari.
Thank you so much. So my case pretty simple, but something which is very common, and I hope you're all going to participate during this presentation. So my title is Lost in the Cycle, the blood pressure swing between chemotherapy cycle. So this is a case of cardiotoxicity beyond heart failure. So why this case? For me, it's just very few things. Each time we think of cardio-oncology, we think of heart failure. We are thinking of patients who have myocarditis who need to be in the ICU. But sometimes the patient is sitting right across your desk. So this is a case of a 54-year-old female who I recently saw. She had been diagnosed with multiple myeloma following surgery, spinal surgery for compression and it was found to be a plastocytoma. So that's the first time we got to know she has multiple myeloma. She had pre-existing cardiovascular disease, a bit of systemic hypertension. She was obese. She was pre-diabetic. She was already on antihypertensives. Baseline echo was normal. ECG was quite normal. Blood pressure was well controlled on antihypertensives. She went ahead and got chemotherapy. So our chemotherapy was bortezomib and dexamethasone plus lenalidomide. And the first thing after our first cycle of chemotherapy, she developed hypotension. So she sent me a message and told me her blood pressure is 80/60. She was at home. She was not very symptomatic. So we agreed she was going to stop her medication, not take the next dose, watch over it. She's a pharmacist. She could monitor herself. And she did. And the blood pressures came up. But that was the last time I heard from her. And I kind of forgot about the patient. So anyway, subsequently the blood pressure developed. However, the antihypertensive therapy was never restarted. So she goes in for a second chemotherapy, and when she saw a hematologist, her blood pressure was 170 systolic. Despite this, she told me, it wasn't a concern. So she got her second chemotherapy, and she went home on high-dose dexamethasone plus her other chemo medications. So the question is, which cardiovascular toxicity do you think is mostly overlooked? I've given you 5 choices there. Who thinks it's hypertension? The one which is most overlooked. Okay, heart failure? Nobody? Okay. Arrhythmia? Mora thinks arrhythmia. 2 people think it's arrhythmia. Venous thromboembolism? 1 person. Diabetes, metabolic issues, syndrome. So what does everybody else think? Are you thinking? Okay, interesting. I actually think it's hypertension. And I don't know how many patients come to you who are on chemotherapy and are sitting across and their blood pressures are up, and you ask, are you on chemo drugs? Do you think that the chemotherapy is contributing to the hypertension? How should we optimally treat this patient? Second question, who should be responsible for managing hypertension during active chemo? Is it the oncologist or hematologist? Should I dedicate that to Dr. Anne Mwirigi? The cardiologist? Should we be referring patients to Morangunga and the others? What about the primary care health physician? The physician who is seeing the patient on frequently. Or should it be a shared cardio-oncology pathway? And I think this is a very important question for us to discuss. Who does this patient belong to? We know that the expected cardiovascular toxicities in multiple myeloma are quite a number. With bortezomib on the picture, patients can present with hypotension, with hypertension, and this can be very tough for the patient. Heart failure, though uncommon, or arrhythmias. And they're on high dose dexamethasone, 40 milligrams. So they do have issues with hypertension, fluid retention, hyperglycemia, and weight loss. This patient was pre-diabetic. She had had 2 months of DEXA. No sugar had been checked. And we know that multiple myeloma drugs related cardiovascular toxicities are quite high. And you can see there's hypertension with lenalidomide, bortezomib, and the others. Hypertension is quite high. These patients can get all the other side effects, and most importantly, VTE. So the patients need to be on VTE prophylaxis. So when it comes to cancer-related cardiovascular toxicity, if we are thinking of hypertension, it is important that our patients, if the blood pressures go above 130 systolic and above 80 diastolic, then we make a diagnosis of hypertension, all right? So the guidelines don't change because the patient has cancer, all right? And then we might consider holding cancer treatment if that blood pressure is uncontrollably above 180 and above 110 diastolic. Very high blood pressures associated with acute hypertension and mediated organ damage, like heart, retina. If they're coming in with an hypertensive emergency or urgency, then we need to reduce this blood pressure, just like the regular patient who you're getting. So we cannot give it as an excuse that, these patients just come with high blood pressure. So for this particular patient, we returned her medication. She's on home blood pressure monitoring, targeting a blood pressure of below 140/90 and continued surveillance. Now, would you have referred this patient, a patient who has high blood pressure, for cardiovascular evaluation prior to chemo? Who would have referred this patient? You are following up this patient, they have hypertension. You've diagnosed them with multiple myeloma. Who thinks of sending them for cardiovascular evaluation prior to? Mora? Yes, okay, very well. And I would say yes, that all these patients with hypertension should be assessed. Cardiovascular evaluation prior to starting their chemo. So the take-home message for me is, with chemo, you can get several changes in the blood pressure. Could be hypotension. You might need sometimes to withdraw your antihypertensives, but then we need to coordinate who manages the hypertension. If it's the oncologist, during chemo, the BP is high, restarts. If it's severe hypertension, don't label the patient as their blood pressures go up and down. Try to manage these blood pressures so that we can avoid delayed cardiovascular intervention, which will eventually now lead to actual cardiovascular disease. Thank you.
Thank you very much, Dr. Kimeu. That is an excellent point at which to segue to Dr. Professor Ghosh. We have seen how people with pre-existing cardiovascular conditions can deteriorate while on cancer therapies. We have seen how cancer therapies that we can't describe cause complications we can't entirely explain and death, and also how high platelets and low platelets can end up in the same situation at various spectra of hematological conditions, as well as cardiac manifestations of cancer from Dr. Mwazo. I'd now like to introduce our final speaker, Professor Arjun Ghosh. He is a consultant cardiologist at the Barts Health Centre in London and University College London Hospital. He was appointed Professor of Cardio-Oncology at William Harvey Research Institute, Queen Mary University of London in 2025. He is the first cardiologist in the UK to be appointed specifically in cardio-oncology and helped establish cardio-oncology services where he works. And he leads the cardio-oncology service at University College London, which has gold category Cancer Center of Excellence status from the International Cardio-Oncology Society. He was the first joint author of the first British cardio-oncology guidelines published in 2021, and is the first author of the National Late Effects Guideline from the BSc in 2026. He's the founding editor of the Radcliffe Cardio-Oncology Educational Platform, and he's on the Education Committee and Examination Board of the ICOS, International Cardio-Oncology Society, and is one of the editors of the second edition of the ICOS examination book. He runs the UK's only National Cardio-Oncology Study Day and helped organize the first Pan-European Cardio-Oncology Symposium. Outside of interesting world of cardiology's newest subspecialty, Arjun is involved in cardiac MRI. That's where he started off before he segued into cardio-oncology and cardio-oncology echocardiography. And he has several national and international leadership and management positions at various cardiac societies in the UK and around the world. He was awarded the top-level National Clinical Impact Award from the National Health Service in 2025, which is the most prestigious as a working professional in the national health system in the UK. So we're privileged to have him with us for our first ever cardio-oncology meeting at Kenya Cardiac Society. So please join me in welcoming Professor Ghosh. Thank you.
Great. Thank you so much, Anne, for that very kind introduction. And I'd like to thank the organizers of KCS and Kesho for the invitation here today. So I think I have around half an hour. I'll try and keep it a bit shorter to give an introduction to cardio-oncology. And I think I'm very lucky that we've had some very fantastic talks beforehand to really set the scene as to why cardio-oncology is important to all cardiologists and also to oncologists. So it's this already been explained, introduction to the problems. I'll be able to kind of go quickly through some of these bits of it. The cardiac problem with different agents also has been illustrated extremely well by the different cases we've had this morning, from myeloma to solid tumors, breast cancer, and there's different side effects. We've already, with Dr. Kiran's talk, understood who is at high risk, and we've also had a bit of an idea about different cardioprotective strategies. I'll talk about echo and monitoring, and also talk a little bit about late effects, and if there's anything else that's left at the end of that, I might try and cover that. So coming on to what is cardio-oncology, and we've already touched upon the 2022 guidelines, and this is a figure 1, and I really like this figure, and this illustrates how cardio-oncology has a role at all points in the patient journey. So on the left-hand side, you can see the role that the cardio-oncologist has as soon as the patient is diagnosed with cancer to identify what is their risk. In the middle, you have the role of the cardio-oncologist during cancer treatment, and as you can see, the risk of cardiotoxicity significantly increases, of course, with cancer treatment. And then in the brown bit at the end, you have the role of the cardio-oncologist in the late effect setting, in the survivorship setting, once the patient has been cured. And at that point, the risk of toxicity is lower, but increases with time. So cardio-oncology has a role before treatment, during treatment, and after treatment. Now, this slide has already been shown, so I won't go over it in much detail, but just to say that depending upon the level of risk at baseline, different assessments and management and surveillance should take place. So what are the cardiotoxicities? And this is very interesting. So this is something that we wrote many years ago now, 2017, so 9 years ago. And at that point, cardiotoxicity was quite simple. It was chemotherapy, radiotherapy, and the different toxicities, and that's it. The same journal, 3 years later, only 3 years later, asked me to kind of write this again. And even in 3 years, we can see that it is very different. And I'll maybe just focus your eye on myocarditis with checkpoint inhibitors and the toxicities with CAR-T therapy, chimeric antigen receptor T-cell therapy, hypertension and shock. So just in 3 years, there's been a massive change, and that is 2020. We are now in 2026. Already, of course, the landscape is again different. So at that time, the big question was, how can we define cardiotoxicity? And we saw in the last talk by Dr. Redemptor that it should be beyond left ventricular systolic dysfunction. So this is a paper that we wrote again in 2018, so some years ago, just highlighting that it is not just left ventricular systolic dysfunction. It is hypertension, it is angina, it is ACS, it's Takotsubo, peripheral vascular disease. And the drugs on the left-hand side are some very commonly used drugs in solid tumors, in GI cancer, in malignant tumors of hematological origin. So just to say that there is a wide range of cardiotoxicity. And what happened after this was that this was something that in the ESC guidelines they really decided to focus on. So they defined cardiotoxicity as 5 different types. They talked about cardiac dysfunction. So this is very simply, left ventricular systolic dysfunction as type 1 toxicity. They then talked about type 2 toxicity as the checkpoint inhibitor-related myocarditis, and then they divide that into major, minor, depending upon LV dysfunction, symptoms, etc. They then have the type 3 toxicity, which is basically vascular toxicity. And here this is coronary artery disease, peripheral vascular disease, MI, ACS, and so on. They then have type 4 toxicity, which is basically the last case that was discussed, which is arterial hypertension. And then the final toxicity is basically cardiac arrhythmias. So this is how they define the toxicity, the 5 different types. And I think that this was important because, others, we had tried to define toxicity, but there was no guideline which really said these are the different types. I think this is, an evolving area, but nice to have this definition. Then we have cardiovascular risk assessment, and Dr. Kiran has already covered this, so I will kind of not really go into too much detail. But I like this figure. Again, this is figure 1 from this document. And I would suggest to you all that you as cardiologists have all seen these patients in your clinic. And I, at least in my clinic, we see these patients every day. So the first patient is somebody who has a new diagnosis of cancer, who comes to see you, and you are assessing them to try and prevent them developing cardiotoxicity. Patient number 2 is somebody who's previously had cancer and now unfortunately has a second cancer, and again you are trying to see them to minimize cardiotoxicity. The third patient is somebody with pre-existing cardiovascular disease, and you have to see them to try and decrease their cardiotoxicity. The fourth patient is somebody who previously had cancer, had cardiotoxic treatment, developed cardiotoxicity, and now has a second cancer, and you have to try and prevent cardiotoxicity as much as possible. And the final patient is somebody with pre-existing cardiac disease who had cancer, developed cardiotoxicity, and now has a second cancer, and you have to see them. And we very, very commonly see all of these patients in every single clinic. Now, what are the main concepts when we talk about risk assessment? And Dr. Kiran very nicely covered all of these. But these, I would say, for all of us as cardiologists, are very common sense. The traditional cardiovascular risk factors can have an impact in terms of their cardiac outcomes and in terms of the effect or implication that has on interruption of cancer treatment. So we should be assessing them from a general cardiology viewpoint. And of course, in some patients, troponin, BNP at baseline, ECG, echo, etc. Now, what do you do with the risk results? That, of course, is the big thing. And I think that this is something that really should be done by the oncologist. And I'm not saying that the oncologists necessarily have to do a detailed risk assessment, but a very basic risk assessment, are they hypertensive? Is their blood pressure controlled? What is their cholesterol like? What is their, are they diabetic? This will allow you to determine are they low risk, moderate risk, or high risk? And there is a formal risk assessment score that Dr. Kiran already mentioned in his talk. And depending upon their level of risk, they need closer or less close monitoring and follow-up from oncology and from cardiology. And this is something that, of course, many cancer patients also require surgery for the treatment of their cancer. And depending upon their pre-existing cardiac comorbidities, depending upon the treatment they've received, neoadjuvant, chemotherapy and other therapies, their risk can be high or their risk can be low, and this needs to be taken into context. And it's the same thing, of course, with radiotherapy. When patients are receiving radiotherapy from the cancer treatment side, they need to be assessed, and there are high-risk patients and low-risk patients. And the patients who are the high-risk patients are the ones who are receiving mediastinal radiotherapy, where the heart is in the field of the radiotherapy, and the dose of the radiotherapy, the amount of grays they're getting, and also if they're getting high doses of anthracyclines. And if you identify a patient as high risk, really the aim is to try and minimize their cardiac risk factors and control the cardiac risk factors before the treatment is given. So now moving on to one of the newer therapies that Dr. Anne mentioned in her talk, checkpoint inhibitors. And this is way back in 2018, a number of these kind of talks and papers that came out. And this was the original paper from 2016 by Javed Mosleh and colleagues, which was a letter in the New England Journal of Medicine. And ICI toxicities with checkpoint inhibitors, very commonly used drug in lung cancer, renal cancer, melanoma, and there are a number of different direct and indirect toxicities that can occur in the heart, from myocarditis to different types of heart block to cardiovascular instability affecting the thyroid and adrenal. And again, CAR T-cell toxicity, if you think back to that paper from 2020 that I wrote, these are the newer toxicities, and this is something that, we illustrated in this paper in JACC. And as you can see, the CAR T toxicity, which is a very commonly used treatment for a lot of the hematological malignancies now, really you can get this cytokine release syndrome, which really can make the life difficult for the patient. And there's a lot of different toxicities that can occur with the cytokine release syndrome. There's an on-target off-tumor, there can be a off-target off-tumor, and there can be an on-target on-tumor pathophysiology. And the reason that this is important is that the patients who have a higher degree of cytokine release syndrome and toxicity with a troponin release unfortunately have the worst outcomes in these patients, and it can be associated with cardiovascular death as well. So while the treatment is extremely effective, unfortunately it can have significant cardiovascular complications, and we just need to try and be aware of this and try and manage the patients and risk stratify them. So again, very much coming back to the theme of risk stratifying and identifying the highest risk patients. So now if we move on to cardioprotection, and again this is from the ESC guidelines, this is some ways in which we can try and minimize the risk of cardiotoxicity or cardiac events. And you have the baseline risk assessment, and you can really from the oncological viewpoint minimize the use of cardiotoxic drugs if the patient is at high cardiac risk. Now, if the patient is at high risk and the drugs that will be offered are of significant cardiotoxic potential, then pre-treatment with ACE inhibitors, beta blockers, statins, the use of cardioprotective agents like dexrazoxane, liposomal anthracyclines, these are different ways in which you can try and prevent cardiotoxicity. And again, coming at it from a very general cardiac point of view, cardiac rehabilitation, prehabilitation, exercise, stopping smoking, all of these are associated with better outcomes and the obvious things of controlling blood pressure, cholesterol, and diabetic status. And during treatment, there is evidence to suggest that dexrazoxane, liposomal anthracyclines, beta blockers, ACE inhibitors, and statins, as I mentioned, all can be protective in different ways. And this was a very nice meta-analysis by Ariana Macedo and colleagues from Sao Paulo. And what she did was look at a lot of different types of studies that have been published using anthracyclines and the role of dexrazoxane in protection. And as you can see from the forest plot, very much, the diamond is on the left-hand side, suggesting that the use of anthracyclines with dexrazoxane in this context is cardioprotective and decreases the likelihood of LV dysfunction. There are a number of trials. This is Overcome trial on hematological cancers, the use of ACE inhibitors and beta blockers, as you can see on the left-hand side in the intervention group, ejection fraction did not fall if ACE inhibitors and beta blockers were used compared to the control group where there was a decrease in cardiac function. And what this also shows is that the patients are more likely to complete their cancer treatment with this combination. This is a breast cancer cohort from Gita Galati and colleagues in Scandinavia. And what she showed was that if you were to use candesartan, less likely for there to be a fall in ejection fraction. And if you were to use metoprolol, less likely to be diastolic dysfunction. And this is a contemporary cohort of patients from 10 years ago where they had anthracycline therapy, they had HER2 therapy, and some patients, of course, had surgery and radiotherapy as well. And coming on to primary prevention, what did the ESC say in their guidelines? And they really talk about the generalized risk factor assessment, and then in terms of dexrazoxane and liposomal anthracyclines, this is a 2AB recommendation. And for ACE and ARBs, again, 2ABs, 2AC. So what you can really see from this is that the evidence base is quite low. This is not class 1A evidence to use these agents. So really, this is where all of us in the room, all of us around the world can try and do the cardio-oncology trials, do the large databases, the registries, the meta-analysis to try and improve the evidence base so we can move from a 2AB to a 1A and so on. What about monitoring? And even before monitoring, how do we define left ventricular systolic dysfunction? So again, we wrote this in 2018, and at that time you can see the different types of definitions of cardiac dysfunction. American Society of Echo, ESC, National Cancer Institute, Canadian Cancer Society, ESMO, the European Society of Medical Oncology, all of them had different definitions of left ventricular systolic dysfunction. And then even in this paper from Jennifer Liu and colleagues, you can see that the monitoring of patients on cardiotoxic treatment was very different depending upon whether it's from ASCO, whether it's from the FDA, etc. So this is why in the UK we decided to produce our own guidelines. So this was the first national guideline in the UK on cardiotoxicity that Rebecca Dobson and I led this group. And what we really wanted to try and define is what is cardiotoxicity for the UK population based on echocardiography. And this was the first guideline in the world where we suggested that the patients who needed surveillance did not need a full echocardiogram each time. These are the patients on anthracyclines or HER2 therapy. And what they needed was a targeted echocardiogram because the main dysfunction would be left ventricular systolic dysfunction as identified by 3D-EF and changes in GLS. So we introduced the concept of a targeted echocardiogram or a focused echocardiogram for the surveillance studies. And at the end of treatment, a full echocardiogram to try and define is the patient low risk, medium risk, or high risk in the late effects setting. And what is the role of biomarkers to identify cardiotoxicity while treatment is happening? And I think this is a very important point that the ESC guideline raised, that a baseline BNP and troponin is extremely helpful because we often see the patients and they come, once a problem has occurred and their BNP is elevated, their troponin is elevated. But the question always happens is, was the troponin normal at baseline? We know from a number of population studies that patients with cancer have an elevation of troponin many times at baseline, and that's due to the pleiotropic effects of the cancer itself. So knowing this obviously makes a difference when the patient then presents with a troponin elevation. Is it a true elevation or is this something that was there from before? Coming on to the late effects setting, and again, there are a number of different late effects guidelines from the UK and also from around the world, International Late Effects Harmonization Group, and then the Children's Oncology Group. And even, this is quite old actually. This is from 2014, if I'm not mistaken. The American Heart Association, already at that time, they were thinking about late effects and the problems that childhood survivors could have with cardiotoxicity. So as cardiologists, we were thinking about this from quite some time ago. So in the UK, this is something that we published, myself, Victoria Grandage, and the British Society of Echo and the Children's Young People's Cancer Association a couple of months ago, actually, in May. And this is really just to kind of focus on how we should be doing late effect screening in the UK. And what we really decided to look at are, again, coming back to that same thing about the risk stratification, because this is the most important thing. And the high-risk patients are the ones who received high doses of anthracyclines and high doses of radiotherapy, and the low-risk ones are the ones with less anthracycline and less radiotherapy. And the way that these recommendations were come to were based on Markov modeling, health economic modeling, and in every society there are limitations to the amount of resource that is present. So the resource really should be focused on the ones who are highest risk. And what we suggested was that the high-risk patients have 2 yearly echocardiography, the lowest-risk patients have no routine echocardiography, and the moderate-risk patients at every 5 years. And this is based on health economic modeling. And then, for adults, of course, following stem cell transplantation, there are guidelines. Again, for lymphoma, there are guidelines. For myeloma, there are guidelines. Again, after stem cell transplantation, more guidelines. And this was something that was also looked at by ESMO, and they published this, from ASCO, from the American Society of Clinical Oncology. And coming on to this, and this was already shown by Dr. Kieran in his talk, that there are different strategies, and again, for the late effect surveillance, very much depending upon your level of risk. So coming towards the end of my talk, and I've hopefully managed to cover risk assessment, different types of toxicities, and also monitoring, but there are certain things that I didn't cover. So, cardiac tumors, and this is something that, we wrote a few years ago, and this is part of my work, but probably this is maybe 2 or 3% of my work. The vast majority of my work is, of course, not cardiac tumors, but cardiac complications of therapy. We didn't talk about education and training. And again, this is something that we wrote for JACC Cardio-Oncology, and this is an extremely important part of cardio-oncology. Events like today, and I must say that this session I've really enjoyed myself. It's one of the best sessions, I have to say, honestly, that I've been involved with, because all the cases were very real, common cases that all cardiologists, see. We run a very big cardio-oncology training program at Bart's Heart Center in UCLH. So if there are any interested trainees, please do get in touch if you want to spend some time at Bart's and UCH learning about cardio-oncology. And I think this is extremely important that, I'm here giving the talk today in Kenya, and cardio-oncology is not the same everywhere. And this is a survey that we conducted, and I understood from Dr. Murigi that they are conducting a survey at the moment in Kenya along similar lines, looking at training in cardio-oncology. And we published this year, and just to show that across the world, so this is really cardiology trainees were approached across the world through the International Cardio-Oncology Society. And as you can see, the majority of trainees do not receive formal cardio-oncology training, and this really has to change. And probably the trainees in North America and UK get a little bit more, trainees in the rest of the world get a little bit less, and of course this has to change. And as you can see, that the amount of training also that they're getting is not much. There are some places where the amount of training is very low, less than 10 hours. Some places it is more than 50 hours, and this does seem to depend upon whether the patients are in South America, in Europe, in Africa, in Asia. So there is a geographical change. And of course, we really must be trying to change these for better outcomes for the cancer patients with cardiac issues. So how can we improve? And this is, I think, the last paper that I'll be talking about. And this is something that I was involved with from the ACC and also from ICOS. And really, what we should be looking at is quality of care. And this is something that we published last year. And I think this is where the future should take us in cardio-oncology. And what is the future? So as you can see on the left-hand side of this figure, this is kind of where we were or where some countries are when they're starting out in cardio-oncology. And at that time, a lot of quantity, a lot of different patients, and it's very much about trying with limited resources, lots of patients, to just make sure that they have a safe cardio-oncology journey, they can try and complete their cancer treatment safely. And with time, with experience, what we should be doing is moving or trying to move towards the right-hand side of this graph. And what we're then doing is, with our experience, improving our systems and really focusing at that point on quality rather than just on quantity, so we can achieve the best outcomes in terms of morbidity and mortality for the cancer patients with cardiac issues. So in summary, really cardio-oncology is, I probably need to change this slide. It's not new now, it's newish, or not so new, but it does really bring together oncologists and cardiologists. We have medical oncologists, cardiologists, hemato-oncologists, cardiologists. So this is really what cardio-oncology it is. It is a communication between oncologists and cardiologists. And I hope that all the fantastic cases that we had from the different speakers earlier this morning really illustrates that all of you as cardiologists, you see these patients already in your daily practice. And it's the same for the oncologists. They obviously see patients who have cardiac complications. So we are all seeing these patients anyway. And it's extremely important, as we've decided or discussed in some of the cases, that these are seen by interventional cardiologists. They're also seen by electrophysiologists. We talked about the pacing issues. We talked about heart failure, and we talked about the role of imaging. So all cardiologists, all subspecialties in cardiology see these patients. And really, at the end, hopefully I was able to convince you that cardiology and oncology trainees really do need to get training in cardio-oncology. And there are very many research, educational, and training opportunities, because cardio-oncology is really a very fast-growing and exciting developing field. And the last point is that we really need to move from quantity to quality at this moment. If you're interested in further resources, there's the ICOS podcast on Spotify. There's a lot of different journals like JACC Cardio-Oncology, ACC Cardio-Oncology, ESC, and the Radcliffe Cardio-Oncology Hub. And I'd just like to acknowledge and thank my research and clinical teams. Thank you very much.
Thank you. Thank you very much, Professor Ghosh Arjun, for that excellent talk. It's amazing that you managed to cover such a huge breadth of cardio-oncology work over more than a decade. And I just want to welcome questions from the cardiologists in the room. We'll go with ladies.
Thank you so much, Professor Ghosh and the rest of the team. This was really an excellent session on a Saturday morning with very good attendance. Congratulations, very well done. Yeah, so my question really is bringing this new subspecialty that, not newish, you said, newish, that is fast evolving into the patient. We know that we capture acute and subacute complications quite well now, working in collaboration. But recently I had a lady who had survived breast cancer come to the office 6 years into remission. So they have done a good job, they have won. But then she comes in and she's in acute decompensated heart failure, and it's a late presentation. But then at some point, 1 year, 2 years post-remission, she was like, you're quite stable, I'll see you in 5 years' time, or an echo in 2 years' time. From your own experience, how do you think we can capture these patients who we win big wars and then we're ambushed by a grenade that we don't anticipate coming? How do you think we should go about this? Do we need maybe to refine our guidelines? Do we maybe need to refine our clinical context to include if a patient develops a second hit, cardiovascular-wise, like diabetes, hypertension, does that mean then they need to be followed closely? Do we need maybe to screen a bit more in terms of CV screening and risk stratification a bit more frequently so that we don't find ourselves in these situations?
I think excellent question, and a very common and practical question around the world, really. I think that if you look at some of the late effects guidelines, it again comes down to identifying the risk. So in that patient you described, probably they would be low risk actually, right? They were female, they were young, they didn't have any cardiovascular risk factors, and the treatment is over. So in that situation, probably I would say that if you look at the guidelines, they won't recommend any necessarily formal screening in these individuals. So the onus at that point is really on the oncologist and the cardiologist to say that, look, you have had treatment which can affect your heart. For example, if it's a breast cancer patient, they may well have had anthracyclines. Commonest time for the anthracyclines to develop toxicity is actually 7 years. That's the median time. So although the patient is at low risk, you probably tell the patient that if you do have any symptoms, shortness of breath, don't forget you should talk to a cardiologist. But it's a very, very real, difficult problem. And I think at the moment in the low-risk patients, we don't have good tools to predict which ones will develop the toxicity, hence the focus very much on the higher risk patients, but this is an evolving area.
Thank you, Dr. Ajun. My question, I'm not sure if it is for you, but this drug dexamethasone, that one, who uses it? Do you even use it in England? And why is the use not so... I don't know, I've never seen in this part of the world, but I just want to understand.
I mean, I'll answer for myself and then I'll hand over to the oncology and the hematology colleagues. But so it is used quite frequently in the UK, and it's mainly used for sarcoma patients, and it's also used for breast cancer patients after they've received certain doses of anthracycline, so probably more than 250 milligrams as an equivalent, then they are given this. There was a concern amongst oncologists before that using the dexrazoxane potentially made the cancer treatment less effective and that the cancer outcomes was not as good, even if the cardiovascular outcomes was good when dexrazoxane was used. However, subsequent meta-analysis have shown that that's not correct, and that dexrazoxane does not impact negatively in terms of the cancer treatment outcomes. So in the UK, this is the use, but of course, we should be using it more. And currently, right now, we're in the process of setting up a national study in the UK to try and see if we can improve the use of dexrazoxane more widely. But we probably need the help of the oncologists. I think over to the oncologists.
Yep. So we've never used it at Aga Khan for sure. Of course, we've talked about it. I think we basically stick to ACE inhibitors and beta blockers and other cardiovascular risk modifying measures in concert with cardiology, but I don't think I've never used it. I don't know whether Murigi, you have?
I don't even think we have the drug at Aga Khan. When we had our cardio-oncology CME last year in August, I think Dr. Kariuki and Gladwell were saying that they use it sometimes at Nairobi Hospital. But I have to say, I'm a little surprised that they're using it in the UK now. The slide I shared about the previous binary approach to anthracycline toxicity is exactly what was happening when I was training. And basically what you would do is just, patient is at risk of anthracycline toxicity, and you would decide either to omit the drug, to give an alternative, or reduce the dose. But there was never any kind of proactive cardioprotective, not even an ACE inhibitor. It was just use a different drug or monitor the heart closely and decide when to stop. Yeah, so it was definitely reactive, not proactive in that sense. Yeah.
But which is, I guess, why we have cardio-oncology now to change that mindset. So.
Yeah.
So dexamethasone is just an ion chelator, and I've had the privilege to work with Charles. Yes, under special situations, we've had to import it, under special license. Yeah, but it's a drug. Initially, as you say, in the literature there were those mixed opinions, but I think in the right patient at the right time, it's a good drug. So. Thanks.
Yeah, thanks. Great presentations. Just like to make a comment about the role of counseling for patients who have cancer and cardiac diseases. honestly, it's a nightmare, the kind of cases you presented here where a patient comes in with an SES kind of scenario with low platelets, with everything down, the kidneys are gone, and you do not know what to do. Some people next of kin may give you advanced directives what to do, and that really saves you as a clinician, because you honestly do not know whether to go take these people to cath lab and fix stents, as we've had here, and to decide on antithrombotic agents and so on. So I think counseling for these patients, especially those who have very aggressive disease, is really important, so that some of these decisions can be made and save you the trouble of not doing so aggressive interventions that will not pay. I can imagine even the nephrology guys, if they were here, they would tell you the same thing. This patient who comes in and develops acute kidney injury with everything out the roof, do you actually intervene or not? Second point, maybe Professor Ghosh, this issue of risk assessment for whether to initiate cardioprotective treatment or not. I think most of those scores, I don't know what populations they were used on. Do you think they are easily applicable to most populations across the world, especially with other competing cardiovascular risk factors? What is the weightage of each of those points? Age, we have very young patients in our cases here who get cancer. I don't know how many points age scores, for example, in those systems, algorithms you have, if they could actually be underestimating the risk for some patients in some geographical areas. And while at that, I would like you to make a comment on the role of SGLT2 as a cardioprotective molecule. Is there some good data to see if we can use SGLT2 also?
Yeah, so maybe I'll answer the second question first. So there is data for the SGLT2 inhibitors, and there are reviews, even we've written a review that it can be used in this situation. And I think kind of tying it in with the first question. So the risk scores are good, of course, but they're not perfect. And if you identify a patient of high cardiac risk, the big question is, if the cardiac function is completely normal, is there any role at that point of giving the cardioprotection? And if you look at any, say, heart failure guideline, they will say no, patient has no symptoms, cardiac function is normal. But we definitely see in the high risk patients that there is a risk of the cardiac function deteriorating. So you have two options at that point. One is you give them cardioprotection, or the second option is you don't, but you monitor them very closely. You do echocardiography maybe every 2 cycles rather than every 3 cycles. You may do biomarkers such as troponin and BNP closely. So I think that these patients where there is a lot of nuance, you need to have the MDT discussion and work closely with the oncologist to make that call. And I think also, again, coming back to the guidelines and things that I was quoting, you can see the evidence level is 2A, B, 2A, C. It's for this situation that we need the larger trials, the prospective trials, to try and improve on that. And the final thing I will say is that the trials that I mentioned, for example, the PRADA trial, which is only 10 years old, breast cancer, the total number of those patients who are very high risk is actually quite low. So the trials need to be really significantly powered in terms of number of patients to identify the ones that actually develop cardiotoxicity. But I'd be interested also just to hear what Dr. Kieran thinks, because you talked a lot about the risk profiling, what your views are.
An excellent question, Dr. Samia. All I can say is, the idea here is to form this association and have enough numbers so that we are also able to generate data that we can contribute to the world, show them that we have these patients and probably these risk scores probably are not applicable to our population. But we've got to start from somewhere. Just on an educational point, the HFA, Heart Failure Association, ICO score applies for 6 classes of chemotherapeutic agents, as I mentioned. And as you saw in my slide, we have a lot of patients also who have prostate cancer. So for prostate cancer, we don't use HFA ICO score. Prostate cancer end up receiving androgen deprivation therapies that also lead to a lot of metabolic syndrome, hypertension, diabetes, dyslipidemia. For them, they use another score. We use the European score, and score OP if they're above 75 years old. Okay, so that is where now the score 2. So these scores are online, they're available. You are able to put your patient into that score, and then you're able to see what to do at the beginning and how frequently the follow-up schedule, end of treatment, and long-term follow-up. So there is some tool that is helping us. Yeah, but I agree, it's not validated in our setup. We need to come together, contribute to research. On the first issue, you talked about counseling. I think it's an important aspect. Maybe Anne will talk about that. But the idea, again, of this meeting is to sensitize the people that not all acute coronary syndrome in patients with cancer need to land up in the cath lab. Because as you saw, these patients are already very sick. They have multiple comorbidities. You are exposing them to contrast that may not have been necessary. Some of these are type 2 MIs. Some of these are just transient side effects related to the chemotherapy. The fluoropyrimidines like cisplatin can cause coronary vasospasms that you did not need to really, you probably needed to just medically manage the patient. So we are here to create the environment in which we can build on the knowledge so that we are appropriately managing these patients. Over to you, Anne.
Thank you, Dr. Mwazo. Thank you, Dr. Samia. I did kind of put Dr. Ngunga on the spot in the heat of the moment, but actually that case was to illustrate there is no correct answer for a patient presenting with long-term thrombocytopenia in the context of poor risk disease and a new MI, okay? And I think that what we were highlighting was the need to have a collaborative plan, which does begin with very candid communication with the patient and family to say, we are truly between a rock and a hard place. Your platelets are very low, despite which it looks like you have a life-threatening clot in your heart. We can give you blood thinners, they may cause you to bleed. We can give you blood thinners, they may do nothing and you may die. The best treatment might be an angiogram with a stent, which you cannot have because your platelets are forever 30 or 60. So we can come up with a best case scenario collaboratively and see whether it works, but we're giving you no guarantees it's going to work. So either we do something conservative or we try this fully knowing it might not work and you might still bleed out or you might still, So it's a kind of candid conversation that lends itself to the next plan of action, and it's a multidisciplinary discussion involving the family, the patient, and our respective specialties. In this case, it seems to have worked. The patient is still alive and relatively well, but he does still have today a life expectancy of 1.5 years.
Thank you all so much for wonderful, really candid discussion. And we've touched on one part that is really, I think a lot about, which is health systems and how we navigate the care, the journey for someone who has both a cardiac and oncologic disease. And often where I practice in the US, the same tension exists. And we talk about, okay, then what's the table of truth, which is usually the cath lab, but there's also the MRI table, which is the table of truth. Contextually here, as we think about what the future looks like, what are ways we could build systems to think about having ready access to cardiac MRI for patients? Is it that the machine's expensive, the training is expensive? Do we develop centers of excellence and just have 2 or 3 centers around the country where as soon as this decision becomes... When I see an ST elevation on an EKG with troponins, it's very hard to turn off that switch in my brain that has been scarred over the years to say this person needs a cath, and I have to pause and reflect, and then I tell the oncologist this is, it's the toxicity, and they say actually it's the heart, and where's the table of truth? How do we have more access to people? And also to understand there's some reversibility. If we see fibrosis, then we know it's done versus just edema, and it's just a pause in the medicines, and we get back to business.
Wow, that's an important question which has been posed there, and I don't know whether any one of us here has the answer. Anyone with an answer, an accurate answer of what can we do locally? honestly to improve the situation. So Dr. Mzengunga will try to answer that, and then we are going to be wrapping up this session in just a few minutes.
So I'm not an oncologist, but I do understand the systems of care that do benefit patients. I was just talking to Jubrin here that cancer is, it's true you can be cured, but that cured is basically just a quote, if I can use that word. It's true you can go into remission and you are good. I don't know where the oncologists send their patients after they tell them they are cured. In my clinic is full of patients who I meet in casualty, who were treated for their breast cancer, lymphomas, coming like Mora's patient. Because even for us, we have cardiomyopathies which say they have recovered, they are cured. Most of them disappear. But we need a primary care system that where you are happy your lymphoma is cured, if I can use that word, hypertension is cured or controlled, they have to go to a family doctor who basically watches these patients. And they do all those things we are talking about, ECG, echo, CT scans regularly, and they just follow, because a cancer patient, sometimes they can have recurrence of the tumor or recurrence of anything else. First of all, I can tell an example of Jubrin's patient who came with dyspnea. If you ask them, their biggest fear that the cancer has come back. They probably went back to the oncologist or went to somebody, because you don't even think about the heart as the cause of your new dyspnea. So they think they have, the cancer has come back and it's causing all manner of problems. So if you look at, I was even talking to that man from Shah yesterday. So it is true, there are lab packages which basically help solve that problem that Gary is talking about. So the lab packages, whether it is enough or not enough, another story. That means the package takes care of not just the MRI, but the CT scan, the biopsy. I saw them here. I met the man from Shah and he sent me the stuff. So those packages are one way of addressing those problems, because you can't just treat cancer, because cancer is a CT scan, biopsy, surgery, chemo is a whole process. And so someone is thinking about it. So, and this is indeed the right steps in solving a complex problem.
Thank you so much, Prof. Mzengunga. And maybe just back to Arjun, what is your experience in the UK with this kind of patients? Are they the patients who you're seeing? Do you have another healthcare system or someone else who takes care of them? And then after that, we shall be taking a comment from Anne Mwirigi, then Dr. Mora, as we close.
Yeah, thanks. I mean, I think it does depend on where you work. Where I work, we have a lot of cardiac MRI. We do 30 cardiac MRI scans a day, so it's very simple. But I think that, just to answer the question, in terms of resources, probably if you are setting up cardiac MRI services in a country, starting with centers of excellence is the first step, and then increasing the training in cardiac MRI, and then persuading your local radiology departments to allow you to have one slot a day for a cardiac MRI is the way to start. And then in the UK, we're very lucky that most cardiac MRI is done by cardiologists, not radiologists like me. I'm a cardiologist, I do cardiac MRI. So I think education, training of cardiologists, and then expanding it is the way forward.
Thank you so much.
Thank you.
And
thank you, Arjun. And thank you, Dr. Ngunga. I'm going to address the point of trying to avoid my 5-year-old post-lymphoma patient ending up after anthracycline in casualty in heart failure. And lymphoma, AML, whatever, the patients are going to come to me every year for follow-up, actually. They like to come to verify they're cancer-free. And at some point after year 2, I tend to try to make it worth their while. I always ask them, are you doing a wellness check? Okay. Can you please do lipids? Can you do HbA1c? Can you do this? I think what is a good thing to do for us when we see these patients, because these are the only patients who want to come to you when they're healthy, because they want you to verify they still don't have cancer 3-5 years on. And one thing I can add to that list is book an echo or a troponin or something. Book an echo maybe. that's, I know Arjun said we don't need a full echo, but just to avoid your kind of patient morale, I don't think it's a waste to do them an echo once a year or once every 2 years or something like that if they've been exposed to a good dose of anthracycline because of chemo.
Thank you so much. Any burning comment?
Yeah, I was going to make a comment and say the one thing that I think will make a big difference, particularly in our setup, is stop working in silos. The more we start working and seeing these patients as an MDT approach, the more we'll get better outcomes, because then I will kind of anticipate what Anne will be telling the patient. I'm able to throw the patient back and say, I think there's something wrong here. I don't think the cancer is progressing, but when you speak to me, you're panting. I can tell there's something wrong. So I think working as a multidisciplinary team when we take care of these patients will be the first step of saying, when is the MRI required? When do we need to repeat the ECG? Sometimes you'll already pick things, scar on the ECG, and you're like, maybe we need an MRI. And obviously building capacity and centers of excellence.
Wow, thank you so much. I think this has been an amazing session. We can all attest to that. So I'm going to ask our panelists to just give a parting shot, quick and brief. We can start with, please go ahead.
Yeah, so for me, I agree completely with all the sentiments, especially working as a multidisciplinary team, hence cardio-oncology. The parting shot for me would be, and this is just to go back on the previous question, just if you don't mind, just 2 minutes, is that...
Half a minute.
Half a minute. Post-treatment surveillance is definitely a challenge. That is usually, and sometimes the guidelines do not cover the whole spectrum of the cases that you see. So what some places do, and one thing we're thinking about is having a post-survivorship clinic, which necessarily does not need an oncologist there, but you have a clinician or physician that mandates this patient to have a regular follow-up. So that's one way places have done. But in terms of a parting shot, I think cardio-oncology is it's a service that's really needed. There are too many gray areas, and I think we just have to do our own local thing going on. Thank you.
Thank you. Mwazo?
Yeah, I mean, essentially, cardio-oncology is an MDT, as it has rightly been put, and many times you don't need extra resources. In our hospital, we have a robust oncology unit and a cardiology unit. What we're trying to do is to organize ourselves in a manner that we can see these patients sometimes together rather than on an ad hoc basis until an event has happened, and then, yeah. We only have one actually dedicated cardio-oncology unit in sub-Saharan Africa, in South Africa, in Durban. But this is the prime time now for all of us who are here. It's not only for cardiologists and oncologists. We are inviting also the nurses, allied people, the imagers. We are inviting the pharmacists. We are inviting everyone, because as you realize, there's a lot for everyone in this. Yeah, and thank you very much.
Thank you so much.
I think it was a fantastic session. I hope that it has generated interest in cardio-oncology, and really looking forward to hearing about the growth of Kenyan cardio-oncology in the future.
Thank you. I want to thank Kenya Cardiac Society for inviting us as Kesho. I want to say we're in a unique situation for a relatively new specialty. It's only, maybe a decade old, and we're usually 30, 40, 50 years behind. We're actually quite early, and I think it's an opportunity for us to be able to generate our own data, to be able to generate our own grade 1, grade 2 evidence guidelines. And to that end, we wanted to also just say we will be forming a cardio-oncology working group to which you will all be invited to join, so that we can pool resources together, be able to collect patient data, be able to chart the way forward together for cardio-oncology in Kenya, so that it's a collaborative working group with both cardiology, oncology, hematology on board. Thank you.
Thank you, Dr. Mwirigi. I think for me, it's just to say the seed is planted and it is growing. So we want to see you in the next cardio-oncology conference, which we'll organize as we go along. Please join us. Let's make this work. Thank you so much. And I want to thank our esteemed presenters today. Honestly, you've done a good job. A clap for them. All right, so this brings this session to an end, and we are going to be inviting the organizers for the closing ceremony. Karibu bana. You can give us some music there as they organize themselves to come to stage.
Thank you, Redemptor, and thank you to the cardiologists and oncologists forming the so-called cardio-oncology. I was just making a joke with your brain that when you are cardiologists are going to specialize, some will become cardio-oncologists. Dr. Langat will only specialize in treating the right heart failure. So if you have left heart failure, it will refer you to your brain. Yeah, so, but the message is home that indeed cardio-oncology is an emerging topic which we are going to see more and more as we train our doctors. So I think we need to give it the emphasis it deserves. And indeed it's an area that we are watching very, very closely, and not just here, but from all dimensions of medicine, as newer and newer drugs for cancer keep cropping up. So it's really been a great 4 days from the days of the workshop where I was involved in, and I can't believe I'm still here and still having some energy. And to all of you who still have a lot of energy, can you clap for yourselves? This is amazing, and I really look forward to the next KCS meeting. Luckily, Mombasa is always good for us, and we never get tired of coming back, because when we come here, we get a chance to swim. And to Professor June, all the way from London, please take advantage, go to the beach, and make sure you swim and enjoy our maji ya mnazi. Maji ya madafu. Make sure you take him down to the beach and he enjoys the cleansing waters of maji ya madafu. So we are really, really happy to have you in Nairobi. Don't be in a hurry. Karibu nyumbani. To all of you, we look forward to seeing you next year, because next year we shall have another session of cardio-oncology. It's probably going to be longer than this, to be honest, because the idea is to get our physicians to understand the importance of following up their cancer patients, as you have heard, all of you. So as we wait for those very good family doctors to come, you are going to be the custodians of those patients. So once again, the centers of, people keep talking about, every time since I was in medical school, I kept hearing of centers of excellence, centers of excellence. Centers of excellence are not buildings. It is you who needs to be the center of excellence. So don't wait for a special hospital to be built in this country to take care of cancer patients. It is you who is going to be that center of excellence. Because people keep talking about, where are the people from the ministry? Center of excellence, center of excellence. Center of excellence is in the doctors, because you as a doctor, you are responsible for your patient and you do know what needs to be done. And we keep fighting for our patients as the circumstances lie. I play golf, and we are normally told, play the ball as it lies. So we are not going to wait for this center of excellence to come for us to treat our patients. So thank you very much to all of you. Because even when a heart failure patient comes to you, you don't wait for Dr. Ngunga, you treat the patient as you wait for more complex procedures or tests to be done. And that's why we are here to work with you and to make you better at whatever level you are. So thank you very much. Luckily, you are all welcome for lunch at the restaurant. And for those of you who are traveling today, travel well. And we shall see you again next year. Thank you very much.